Hello, good morning, and welcome to our Cardiovascular Prevention Symposium. I'm William Zogby. I'm the chair of cardiology here at Houston Methodist, and it's a pleasure to have with me today Dr. Khurram Nasir, who needs really no introduction. He's our director of cardiovascular prevention and wellness here at Methodist Hospital, as well as the co-director of the Center of Outcomes Research. Khurram, we were really fortunate to recruit Khurram about a year ago, and what a ride it has been. It has been really amazing, and the first thing we thought about is to do a cardiovascular prevention symposium. When we talked about it last year, we were hoping that it would be face-to-face, but obviously because of the pandemic, we have this virtual, and I think there is some advantage to being virtual is to reach more of you. Right, Khurram? I think, and let me tell you, personally, I think cardiovascular prevention is probably among the most important areas that we can tackle. And the reason for it, I think, is simple for me. Yes, I'm not a cardiovascular prevention specialist, but I'm more excited about prevention than anything else. And the reason for it is we can make a difference. Make a difference in longevity and quality of life, maybe even more than many other areas of cardiovascular medicine. Not only in detection, assessment of risk, therapeutics, and so many other areas. So it's really, to me, it's not only for cardiovascular specialists and prevention specialists. It's for all areas of medicine, all areas of healthcare, and also all people who are interested in a good quality longevity life. So what I like about this symposium, Khurram, is it has the who's who in prevention. You've assembled that. And also what I like about it is you can have an early breakfast, some coffee, within half day, be introduced probably to the most influential people in cardiovascular prevention. And I would let Khurram tell us a little bit more about the symposium, how we're going to do that.
Well, thank you, Dr. Zogby. Good morning, everyone, and welcome to the inaugural Houston Methodist Cardiovascular Disease Prevention Symposium. My most gratitude to all the speakers who have joined us today from all parts of the country, some as early as 6 a.m. From the West Coast. I couldn't be more excited about the preventive cardiology field, especially over the last 10 years as we have made significant advancements in early detection, preciser management, wide range of area of biomarkers, genetics, therapeutics, and also including lifestyle. Now, as a result, we believe that preventive cardiology has truly emerged as a subspecialty, providing a very comprehensive approach to the sector of cardiovascular health, enormously increasing demand. And what we wanted to do today with this symposium, with all these who's who in preventive cardiology, to give you a glimpse of how can you take the key messages back to your clinic, your practice, your education, and all the updates that would be necessary. So without due, I'll just give you a brief overview. It will be a very interactive session. The first one, moderated by Dr. Zogby, is what everybody needs to know about preventive cardiology. Followed by one of my favorite sessions, especially related to cardiovascular disease issues, topics in women's health, followed by lifestyle wars, focusing whether stress and diet are some of the things that you need to consider. The fourth session will focus a little bit more about more advances in therapeutics. And finally, our keynote speaker in the fifth session by Dr. Dan Ritter on the issue of familial hypercholesterolemia. What exactly have we learned and what do we need to know? And we will end up with a very engaging debate on whether we should be using biomarkers, genetics, or imaging for further risk stratification. So before I hand it over to Dr. Zogby to moderate the first session, few housekeeping issues. So we want it to be a very engaging conversation today. So if you have any questions, please type in the Q&A box or text Debakey to 37607 and share your questions. And Also, if you're on the social media, use the hashtag CVD Prevention 2020 and tagging at Debakey CV Education. And also regarding CMEs, we'll send you an email next week with evaluation. And of course, we look forward to your critical feedback that will help us improve our courses as especially we explore the new digital segment. So, and again, I want to take a moment to really thankfully acknowledge the following companies who have provided the educational grants to partially support this activities. Number one, Esprion Therapeutics and Novartis Pharmaceutical. We also, I'd like to thank exhibitors for supporting our activities, and I'll encourage you if you could visit their virtual booths, Amgen and Novo Nordisk. But in the end, my special thank to the team at Debakey CV Education, especially Mariana Smith, Jennifer Collins, Cecily Simons, and Tyre Horn, who made all of this possible, especially working hand in hand with all the speakers across the country. So thank you so much, everyone. And now handing over to Dr. Zogby.
A great overview, Khurram, and let's get started. I think the first session, what everyone should know about preventive cardiology. And I think to get us started will be Dr. Michael Shapiro, who's professor of cardiology at Wake Forest and Winston-Salem, who will be addressing the questions on everyone's mind. Why and who needs a preventive cardiologist? Michael, it's a pleasure having you.
An honor and privilege to participate in this inaugural Houston Methodist Cardiovascular Disease Prevention Symposium. I'm going to start the morning off with trying to address the question on everyone's mind, which is why and who needs to see a preventive cardiologist? And I think it's pretty intuitive as to why we would be interested in preventing cardiovascular disease. Fortunately, we've seen over the last 4 decades substantial reductions in cardiovascular disease mortality, but I think that really deserves 2 asterisks. The first of which is it's important to acknowledge the fact that a large portion of the reductions that we've achieved in cardiovascular disease mortality has to do really with several improvements in systems of care, such as the development of CCUs, door-to-balloon time metrics for STEMI, EMS, and lots of advances in technology, whether that be in surgical techniques or in the cath lab with stents and now transcatheter valves. Of course, ICD, ventricular assist devices, these are all great, and they've really helped us to accomplish the goal of reductions in cardiovascular disease mortality. But they allow patients to live longer with significant cardiovascular disease morbidity. And as you know, many of these patients have really remarkable reductions in quality of life. So it would probably be more effective to prevent cardiovascular disease in the first instance. The second asterisk really is maybe perhaps more alarming, which is that we've probably hit a nadir in reductions in cardiovascular disease mortality. And there are projections, and as you can see here in the figure below, that actually we're going to see a reversal in the gains. And this is particularly true in young individuals. And here you can see some graphs over the last years on the left in females, on the right in males, showing that really in the mid-2000s, we kind of stalled in reducing cardiovascular disease mortality. And in the most recent years, it looks like it's really on the uptrend. And this is likely due to the burgeoning epidemics of obesity and diabetes. And really, we have limited potential future gains from further reducing already very low prevalence of smoking. And of course, it's important to acknowledge that persistent inequalities in mortality risk pose significant challenges for public policy to promote improved cardiovascular health. But let me give you a broad overview of the history of preventive cardiology. In my mind, the early days of preventive cardiology, or what I would call the first wave, started in 1948 with the Framingham Heart Study, which of course is a landmark epidemiological study, which identified the traditional risk factors associated with atherosclerotic cardiovascular disease, which of course are hypercholesterolemia, hypertension, diabetes, and smoking. And really, with the identification of these risk factors, I think prevention was born because there were ensuing clinical trials, both in terms of lifestyle modifications to control those risk factors and early lipid-lowering therapies, pre-statins, which demonstrated success. And then I would say the second coming or the second wave of preventive cardiology was really in 1994 with the seminal publication of the 4S trial, which was the first of the statin MECA trials that demonstrated that the use of statins to lower LDL in secondary prevention reduced recurrent event rates and reduced cardiovascular disease mortality. And of course, the statin story is well known. We saw the randomized controlled trials really in all patient groups, and it showed that statins to lower LDL improved morbidity, mortality, cardiovascular disease morbidity, mortality in all patient groups. And so therefore, cholesterol evaluation management became central in prevention, and of course has been emphasized in national guidelines. But I would say that while the early days of preventive cardiology was really focused on lipids and ensuing establishment of lipid clinics, I would say now expert management of lipids is certainly an important part of preventive cardiology, but contemporary preventive cardiology goes well beyond that. And so in a modern program, of course, we try to address all risk factors, both from a lifestyle and medical perspective. So we pay careful attention to diet, weight management, smoking cessation. Of course, lipid management is still central, but of course, we have to remember that blood pressure is extremely important. And there's been a lot of development in diabetes therapies, in oral anticoagulants, and of course, very recently in inflammation, which really gives us a lot to be hopeful about. But I think now we're in the third wave of contemporary preventive cardiology, and we're really just in its infancy. There's been a lot of interest in discussing what makes up a preventive cardiology program and how we can homogenize practice from center to center. But we still are in the early days, but there's a lot of enthusiasm. So let me give you an idea of what common referrals look like to a Center for Preventive Cardiology. Here's just a selection of very common ones. And briefly, I would say that certainly personal family history of premature cardiovascular disease is one of the ones that we see quite often. Or in secondary prevention, those with established atherosclerotic cardiovascular disease who are doing well with their lifestyle and are taking guideline-directed medical therapy, but continue to have events. That would be a great person to see preventive cardiologists. Of course, challenging lipid disorders, challenging hypertensive disorders, risk assessment that may need to go beyond traditional risk factors, looking at advanced lipid testing or other novel biomarkers, subclinical atherosclerosis imaging like coronary artery calcium. A very common one that we see, and I think we can be very helpful with, are the very prevalent condition of statin-associated side effects. And we have a lot of therapies now that we can help patients with who can't get to optimal LDL cholesterol goals with statins. Of course, patients who need lifestyle counseling, whether that's on diet or weight management or smoking cessation, those are individuals who see a preventive cardiologist. Even healthy individuals who are just interested in understanding in a more granular fashion what the risk of cardiovascular disease is. Of course, we're often asked to see patients in consultation for preventive medical therapies or to ensure that whatever they're on is actually appropriate. So here's just a few examples of some patients I've seen in recent weeks, which may give you a more tangible idea of who may need to see a preventive cardiologist. So a healthy appearing woman with no risk factors and first MI at age 42. A young man with LDL of 270 and skeptical that that's a problem. A 62-year-old diabetic woman with well-controlled A1C levels and averse to taking statins. A healthy 45-year-old man whose father died of sudden cardiac causes at age 45. A 6-year-old woman referred for evaluation of HDL of 150 with normal LDL. A 7-year-old man with hypertension and coronary calcium score of 0. And a healthy 58-year-old man requesting genetic assessment of cardiovascular risk. So in the past, we didn't have a lot to offer in terms of risk assessment or management. We relied for risk assessment mostly on Framingham risk score now, the pooled cohort equation, to give us sort of a crude estimate of 10-year cardiovascular risk. And when risk was identified, management, of course, has always been foundational with lifestyle, but statins, blood pressure, and aspirin. But now we're way past that. Now we have much more precise techniques to allow us to find people who are most likely to benefit from our therapies. And on the other hand, people who are most likely safe without getting a whole bunch of preventive medical therapies. And that is due to advances in subclinical atherosclerosis imaging with coronary calcium, coronary CTA, carotid plaque assessment, of course, novel biomarkers, genetic testing, and of course, there's a lot of interest in proliferation and polygenic risk scores for assessment of coronary risk, which will be in the clinics very soon. And really, new and emerging therapeutics that address lipids, blood pressure, diabetes, thrombosis, and inflammation, and really a veritable alphabet soup of new drugs and new modalities, including monoclonal antibodies, antisense oligonucleotides, silencing RNA, CRISPR-based approaches, and even potential vaccines against atherosclerosis are in the works. Now, let me just use the PCSK9 inhibitors as a case study for the importance of addressing all risk factors. Of course, the history of the development of PCSK9 inhibitors is really one of the triumphs of genetics and clinical science, and we now have 2 large randomized controlled trials that demonstrate improvements in cardiovascular outcomes. But when we look at the details here, in Fourier, individuals with established cardiovascular disease who achieved LDLs of 30 on a PCSK9 inhibitor and had an absolute risk reduction in their composite major adverse cardiovascular event rate of 2%, we can still see that at median 3 years, they still had a lot of risk, what we call residual risk, the risk that remains even after getting the LDL to very low levels. And we've really just been focused on LDL in the past decades. I mean, rightfully so, it's evidence-based strategy and we have good tools for it. But even with statins, ezetimibe, and now PCSK9 inhibitors, we see that there are diminishing returns. We can obliterate LDL, we can functionally eliminate it from the risk factor equation, and people at high risk are still at relatively high risk. So we need to now consider all of the buckets of residual risk. And now we can truly consider it because we have tools, effective tools to address all of those issues. So other lipids besides LDL, so a lot going on with triglycerides and lipoprotein(a) reduction, therapies in advanced development. We can address residual inflammatory risk, as you've just seen at recent international meetings, some very encouraging findings. We can address residual thrombotic risk, and of course, a lot of headway with novel diabetes drugs. So there's a lot to be enthusiastic about. But I think preventive cardiology has been synonymous with prevention of atherosclerotic events, and we need to move past that as well. We need to get to the point where we're also focused on preventing heart failure, prevention of atrial fibrillation, and I think in the future, really where it's going to go is prevention of dementia and cognitive decline because of the shared risk factor profile between cardiovascular disease and dementia. So to conclude, I would say that the disturbing trends in cardiovascular risk factors and cardiovascular disease mortality really serves as a call to action, and our attention needs to turn from our historic focus on intervention to really on prevention of cardiovascular disease in the first instance. And I would say the development of preventive cardiology programs is a positive step in the right direction. I thank you for your attention.
Thank you, Dr. Shapiro. Very enlightening, and I think it's a great intro. I can see from what you showed us and what I've certainly noticed in practice, and that you will be busy, meaning the preventive cardiologist will be busy. There's so much work really to be done. And I want to remind our viewers to either use the chat box or send questions through the question and answer, or if you are in a different medium, you can send the text Debakey to 37607. All right. Our next speaker this morning also does not need any introduction. Dr. Salim Virani from next door, Baylor College of Medicine. He's professor of medicine in the Department of Cardiology, heads the fellowship program also at the same time, certainly one of the gurus of preventive cardiology. And Dr. Virani will be talking about comprehensive ABCDE approach to primary cardiovascular prevention, top 10 take-home messages from the ACC AHA guidelines. Salim, it's great to have you.
So good morning. The topic that I have been given to discuss today is comprehensive ABCDE approach to primary cardiovascular disease prevention, and discussing some of the key take-home messages from the 2019 ACC AHA prevention guidelines. These are my sources of research support as well as other disclosures. So like any other guideline, this is really a team effort, and we were very lucky to have a wonderful team that we worked with to come up with this guideline that I believe is a very comprehensive guideline when it comes to primary prevention of cardiovascular disease. Now, before we get into the messages associated with this cardiovascular disease prevention guideline, I thought it would be important to first talk about what does this guideline mean when we talk about cardiovascular disease. So it includes atherosclerotic cardiovascular disease, as you will notice there on the slide. But in addition, it is important that this guideline also talks about strategies to prevent heart failure as well as atrial fibrillation. So keep that in mind when you're evaluating your patients, that it's not just the atherosclerotic cardiovascular disease related events, but also heart failure and atrial fibrillation. The other thing that I would like to mention here is that it would be very tough to summarize the entire guideline in 10 minutes. So what I'm going to do is that I'm going to highlight some very important aspect of these guidelines and some changes that might be important for us as clinicians to really think about when we're evaluating our patients. And I'll give you this ABCDE framework that has been proposed before. I have made a few changes to it to make it more in line with the 2019 ACC-AHA guideline. So you'll see that we have A, B, C, D, and E. A for assessing risk. A is also talking about antiplatelet therapy. B is for blood pressure. C is for cholesterol. C is also for cigarette smoking and tobacco products. C is also for context of care, where we talk about social determinants of health. D is for diet and weight management. D is also for diabetes prevention and treatment. And E is for exercise. So let's go through each of these ABCDEs of primary cardiovascular disease prevention and see what's new. So as I said, A stands for assessing risk. Right now, for any adult 40 to 75 years of age, the recommendation is to perform 10-year CVD risk using full cohort risk equations. And as you will notice here, that remains a recommendation. This is not a change. But importantly, what I would recommend to all of you is to consider that in those who are 20 to 39 years of age, consider a lifetime risk assessment to encourage lifestyle-related interventions that we'll talk about. So remember, in those 40 to 75 years of age, it's still a strong recommendation to perform 10-year risk assessment using pooled cohort risk equations. A also stands for aspirin. What is the role of aspirin in primary prevention? And what we know now, based on 3 large recent studies, ASCEND, ARRIVE, and ASPRAY, we know that the role of aspirin therapy in primary prevention of cardiovascular disease is extremely limited. So aspirin should be used infrequently in the routine primary prevention of ASCVD because of a lack of net benefit. There might be some reduction in ASCVD, but there's also increase in bleeding. So as per the most recent cardiovascular disease prevention guidelines, it's a 2B recommendation. Aspirin may be considered in patients who have a high ASCVD risk, but the bleeding risk remains low. So one has to make sure that whenever we're talking about aspirin therapy, we don't just talk about the ASCVD risk reduction, we also talk about bleeding risk. And remember, it's not recommended for people above the age of 70 as well as those below the age of 40. So keep that in mind when you are evaluating your patients for aspirin therapy. And as I said, it's a 2B recommendation, something that may be considered. The way to remember is to be or not to be. So you may or may not use this therapy. It's not required in primary prevention, as opposed to secondary prevention, where it's a class 1 recommendation. The other thing that is important to remember about aspirin therapy, if you're thinking of aspirin therapy, always ask yourself, have I used other therapies that have more benefit? Those include lifestyle therapy, statin therapy, control of diabetes, and better control of blood pressure. Once you have done all of the above and the risk remains very high based on actual 10-year risk calculation and patient's bleeding risk is low, only then and only then you may consider use of aspirin. B is for blood pressure. Some important concepts here. We know now that normal blood pressure is below 130 systolic and below 90 diastolic. So if our systolic blood pressures above 130, between 130 to 139, it's stage 1 hypertension now. The other important thing about blood pressure now is that even in blood pressure treatment, we are now recommending a 10-year risk calculation. So we talked about A's, we talked about B. C is for cholesterol management. And we know that even in primary prevention of cholesterol, there are some very high-risk groups where we don't do a 10-year risk calculation. Those include patients with LDL cholesterol of 190 or above. In those patients, the recommendation is to go ahead and treat them as long as we have ruled out secondary causes of hypercholesterolemia. The second group is the group of patients with diabetes between the ages of 40 to 75 years. And in those patients, again, generally one would go ahead with statin therapy. If patients do not fall into these two high-risk primary prevention groups, only then we do a 10-year risk calculation, as we talked about, using pool cohort risk equations. Again, if the patient's 10-year risk is 20% or higher, that again usually calls for the use of statin therapy, preferably high-intensity statin therapy, as a class 1 recommendation, something that should be done. And then we have the intermediate and the borderline risk. And in those patients, generally there is room for further risk discussion using CVD risk enhancers and possible use of calcium score to further risk stratify those patients. C is also for cigarette smoking. But remember, the important concept here is that it's not just cigarette smoking, but tobacco use, whether it's smokeless tobacco, chewing tobacco, even looking at e-cigarettes now. And the therapy for that includes first assessment at every clinic visit, then using behavioral therapies, as well as the use of medications now that we have readily available to aid in smoking cessation, as well as cessation of other tobacco products. So remember, assessment is a class 1 recommendation, then using both behavioral therapy as well as selective use of medications to aid our patients in cessation of tobacco products. C is also important to understand context of cardiovascular disease prevention related care, which is social determinants of health. For the first time, the guidelines are now talking about understanding the social determinants. These include housing instability, food insecurity, transportation difficulties, utility assistance needs, interpersonal safety. We can talk all we want about healthcare access, but if a patient doesn't have transportation to come see their healthcare professional, well, they're not going to be able to come, and you're not going to have a discussion about cardiovascular disease prevention. We may say a lot of things about diet, but if a patient lives in food desert, that food insecurity, then we may not be able to give them good recommendations. We may talk about physical activity, but if there are safety issues when a patient leaves their home, it's not going to work. So always contextualizing our recommendations to the patient who's sitting in front of us. When we talk about D, D stands for diet, a diet that is emphasizing intake of vegetables, fruits, legumes, and nuts, and whole grains, and fish. That is recommended as a class 1 recommendation. Replacement of saturated fat with dietary mono and polyunsaturated fat is something that can be considered as a 2A recommendation. And again, reducing cholesterol and sodium in the diet is again a class 2A recommendation. And another thing that is there is to minimize the intake of processed meats, refined carbohydrates, and sweetened beverages. So those are some of the large recommendations related to diet. So moving on, D also stands for diabetes. And what we know is that when it comes to diabetes, dietary counseling as well as physical activity remain a class 1 recommendations. We should not forget that diet is extremely important in diabetes control as well as physical activity. Once that's done, we move on towards metformin as a recommended class 1 agent. And if after that we have patients who have CVD risk factors, in those patients, the use of SGLT2 inhibitors or GLP-1 receptor agonists remain the treatment of first choice. We are not just looking at A1C reduction in patients with diabetes. We're looking at cardiovascular event reduction in those patients. E stands for exercise. But I will give you a few concepts here. First is that you will notice that we are now not using the word exercise. We're talking about physical activity. Any amount and any kind of physical activity matters. The goal remains 150 minutes of moderate or 75 minutes of vigorous activity per week. But there are some important concepts. First, it's not just exercise. Yes, if one can exercise, that's great, but even physical activity that is not exercise is important. The second thing is that you will notice that the curve is curvilinear. It's basically diminished additive benefits as one increases, but you get the most benefit. The curve is steepest in this small amounts of physical activity. So for patients who are not doing any physical activity, some amount of physical activity is better than no physical activity. The second important concept here is that it's accumulated physical activity. Those 10-minute bouts that were there in some guidelines are removed now. So we should encourage our patients to engage in any form of physical activity. Yes, we know that the most benefits we get start accruing at 150 minutes of moderate or 75 minutes of vigorous, but any physical activity is better than no physical activity for our patients. And that is the message that we want to convey to our patients. And then really talking about prevention, that it's a team sport. We know that when we involve our nurses, when we involve our pharmacists, blood pressure control is better. Similarly, the control of diabetes is better. And we have these large meta-analyses showing that it is extremely important to use prevention as a team sport and make use of the full resources we have, whether that is the use of our pharmacists, whether it's the use of our other support staff in the clinic, as well as the use of our nurses and other healthcare professional team members who can really help us in improving the care for cardiovascular disease prevention. So remember, primary cardiovascular disease prevention is as easy as ABCDE: assess risk, antiplatelet therapy, which is of limited benefit, blood pressure control, cholesterol control, cigarette and other tobacco cessation, context of care, social determinants, diet and weight management, diabetes prevention and treatment, and exercise, which is physical activity. And remember, we do it all as a team sport. So to summarize these, again, I'll use this proverb: the secret to living well and longer is eat half, walk double, laugh triple, and love without measure. With that, I thank you for your time, and we will take some questions towards the end. Thank you.
Thank you, Salim, very much for a wonderful summary within 10 minutes of the top 10 take-home messages from the guidelines, ACC guidelines. Let's move to the topic of early heart failure. Assessment and prevention, small investment for huge dividends, which will be presented by Dr. Sadia Khan from Northwestern. She's assistant professor of cardiology as well as preventive medicine. And she will address the early heart failure assessment and prevention. Pleasure having you, Dr. Khan.
Good morning. I'm thrilled to be here virtually with you all, speaking on early heart failure risk assessment and prevention, small investment for huge dividends. Here's a brief outline for our talk. We'll start by discussing changing trends in heart failure, describe tools that we could use for heart failure risk estimation, and conclude by identifying strategies for prevention of heart failure. In contrast with declining mortality rates for ischemic heart disease, worsening trends have been observed for heart failure mortality in the United States. Shown here is data from the CDC, National Vital Statistics System, from 1999 to 2018. In the first panel, we see age-adjusted mortality rates on the y-axis for younger adults from 35 to 64. And in the second panel, we see for older adults from 65 to 84. In both of these panels, what we see is a general pattern of increase since 2011, with significant black-white disparities widening or persisting. Now, why is this happening? We know that the risk of heart failure is increasing in part because of an aging population. But in the last panel, we also saw that there were significant increases among younger adults. two key culprits may be related to the rising rates of obesity and prediabetes and diabetes. If we conceptualize this based on the ACC-AHA stages of heart failure, we can think about the progressive sequential stages of heart failure that really walk us through that at-risk group where there are either not yet risk factors, some risk factors, or structural disease, to symptomatic heart failure in stage C and D. And I'll say that if we really want to make a difference in looking at those people who are hospitalized is really just the tip of the iceberg. In contrast, below the surface, risk stratification and targeted prevention for those at risk will result in the greatest long-term dividends. So now what tools are at our disposal for risk estimation? In clinical practice, no multivariable tools are in place for estimating heart failure risk. Similar to the pooled cohort equations for ASCVD, we sought to derive pooled cohort equations for heart failure risk estimation. In this paper, we were able to pool 5 population-based cohorts with generalizability across the United States for a sample of over 23,000. And we created race and sex-specific equations that incorporated multiple risk factors like blood pressure, glucose, treatment for high blood pressure or diabetes, as well as BMI and cholesterol. This tool is available online for use and has been validated in 2 additional cohorts as well. When we thought about risk, we knew that quantifying based on traditional risk factors was insufficient for heart failure. And shown here is a schematic of several risk enhancers that we want to take into account when quantifying risk for heart failure. COPD or lung disease, chronic kidney disease and chronic liver disease, sleep apnea, cancer therapies and treatments, adverse pregnancy outcomes, which I'll know we'll hear about later as well, and of course, inflammatory viral conditions like HIV and now COVID-19. In addition, for heart failure, we spend a lot of time thinking about monogenic disease risk and how familial cardiomyopathies like dilated cardiomyopathies and hypertrophic cardiomyopathy are inherited, so we can use panel-based genetic testing to identify at-risk family members, as well as potentially change treatment for the proband with heart failure. In addition to monogenic risk, we know that polygenic risk, where commonly occurring variants with small effect sizes in aggregate are responsible for a large proportion of heart failure risk as well. Now, how can we potentially apply genetic risk in the clinic? So one discussion that's really been coming to the forefront is thinking about genomics first. And this really nice paper looked at the multi-ethnic study of atherosclerosis patients or participants, and they identified of the 4,500 participants who had no evidence of CVD at baseline, the 41 or 0.9% of them that were asymptomatic and happened to carry a pathogenic or likely pathogenic variant in a cardiovascular disease gene. And shown here are the different genes that they identified that potentially can contribute to cardiomyopathies, hyperlipidemia syndromes, as well as arrhythmias. And on this y-axis are the number of people with each rare variant. And on this y-axis is the percentage. And you can see these are infrequent or rare variants. But in aggregate, about 1% of the population had a rare pathogenic or likely-pathogenic variant in one of these genes. And then they asked the question in MESA is, what was the outcome of these individuals who had been followed for about 14 years? And what they saw was that approximately 4% of people who did not have a pathogenic or likely pathogenic variant had cardiovascular death over follow-up. And that number was 3 times higher for those who had a variant. Now, these numbers were small in this group, so the confidence interval is quite large. But as more and more people are going to pursue direct-to-consumer genetic testing or are participating in platforms like All of Us, this is going to be a question that we're going to be asked. And if it's about 1% of people, it's not going to be a small number of people. Finally, how do we use biomarkers to think about heart failure risk prediction? In this really nice paper from the BioMarCare Consortium, about 49,000 participants were followed who had about 2,000 incident heart failure events. And the question was asked, in addition to traditional risk factors, does stratifying by high sensitivity troponin level help improve prediction for heart failure? And what they saw was that addition of the high sensitivity troponin marker helped improve risk prediction statistically and altered the area under the curve, or the C index, from 0.843 to 0.848. So how do we put all of this together? I think we'll take a page out of the ASCVD risk assessment guidelines, and I'm sure you're all very familiar with this overall diagram to first calculate the 10-year ASCVD risk, personalize that risk discussion, thinking about risk-enhancing factors, and reclassify with tools like CAC. So I'd like to propose a heart failure-specific CPR diagram where we could calculate 10-year risk for heart failure, personalize that discussion with risk enhancers and considering genetic cardiomyopathies, and reclassify risk with biomarkers and echocardiography. So I'll end by thinking about how we identify strategies for prevention of heart failure and what the state of the science currently is. If we go back to the 2017 or most recent guidelines, there's a recommendation for patients at risk of developing heart failure to use BNP biomarker-based screening followed by team-based care. And this is really the first time such a recommendation has been put in place to think about a risk-based approach. This was based on two main studies that we'll briefly review. The STOP-HF study, which enrolled participants who were being seen in local clinics in Ireland and had at least one risk factor for heart failure, like high blood pressure. They randomized people to either receive BNP screening or their usual care. In the BNP screening arm, if a BNP over 50 was identified, then these individuals were then referred to cardiovascular collaborative care to try to optimize risk factor control. Over time, those individuals who were in the intervention compared with the control had fewer major adverse cardiovascular events, which included incident systolic and diastolic dysfunction. Now, a really cool follow-up study that's ongoing by the same group is examining the role of ARNI in asymptomatic patients with elevated BNP levels as well. The addition in this study is they're also requiring an elevated left atrial volume index. And that's a really neat way to think about how do we further risk stratify with imaging. And I'll be curious to see what they find. The second trial that informed the guidelines is the Pontiac HF trial in diabetes. In this study done in Austria, individuals with diabetes who had an elevated NT-proBNP were randomized to either usual care or intervention with cardiovascular care to up-titrate GDMT therapies. Now, these were patients who were already very well managed, were in diabetes programs, and then were additionally referred to extra care. Over follow-up, those individuals who were in the treatment arm had fewer major adverse cardiovascular events at the 2-year time period. So both of these studies were really informative in helping understand how a single biomarker could help identify those individuals at risk. But I think we have a lot more information now in terms of how multivariable risk estimation, as well as other imaging and biomarker techniques, could be integrated to try to identify those who are at the highest risk. And really, I think the difference today is that we now have great evidence that SGLT2 inhibitors from this meta-analysis that's now already outdated, that even in individuals with no history of heart failure in the EMPA-REG, CANVAS, and DECLARE-TIMI programs had a lower risk of developing incident heart failure with SGLT2 inhibitors. Now, these were among patients with diabetes, and we've now seen great evidence even in populations without diabetes in the CKD and HFrEF populations that really help enforce the pleiotropic benefits of SGLT2 inhibitors. And we know that these agents act on the heart and kidney in many different ways, but importantly, they also directly affect the cardiomyocyte and potentially could be considered the statin of heart failure, given their beneficial effects in prevention of heart failure. So I'll end with some key takeaways. One, most importantly, heart failure is preventable. Second, by identifying risk factors and employing a CPR or calculate, personalize, and reclassify risk algorithm, we can be successful. Finally, thinking about the concept of power of zero could be through application of high sensitivity troponin. While direct-to-consumer genetics is here, it's not quite ready for prime time and how to interpret and follow up. And finally, intervening on heart failure risk can now be broadened beyond optimizing lifestyle and risk factor levels and consideration for incorporation of SGLT2 inhibitors in those with diabetes and more to come. I think with these tools in place, transforming the paradigm from heart failure to heart success is possible. And thank you so much for your time and attention. Happy to take questions.
Thank you very much, Dr. Khan, for this very nice overview of early detection and prevention of heart failure. Certainly a very prevalent disease and with a lot of morbidity and mortality. I like the way some of the studies are bringing in imaging in addition to biomarkers to do that, because as we know, the left atrium is probably among the most sensitive indicators for diastolic dysfunction. So I think it will be interesting to see what the outcome of that study will be. Our next speaker is Dr. Anne-Marie Navarre from University of Texas Southwestern, just a little bit north of here. It's great to have her. She will be talking about dilemmas in hypertension management. Is 130 truly the new 140? Great to have you.
Thank you for the opportunity to present. For the next 10 minutes, we'll be talking about hypertension management and whether 130 is really the new 140. I put this talk together while at Duke, but recently transitioned to UT Southwestern. These are my disclosures. So I think the shortest answer to this question really comes from a review of the most recent guidelines. And I really like this ACC document, Guidelines Made Simple, which sort of goes through the 2017 guideline and breaks it down into sort of more digestible bites. And if we look at this table, one of the things that the recent guideline did that was really revolutionary is they redefined hypertension. So we used to say hypertension started at 140 and you were pre-hypertensive below that, but now we actually categorize stage 1 hypertension as 130 to 139 systolic and 80 to 89 diastolic, with stage 2 hypertension of 140 over 90. And then what the guideline did is kind of broke down treatment by stages of hypertension. So what we're talking about today is this sort of 130 to 139 cutoff. And here, the short answer in is 130 the new 140 is it depends on who you are. So if we look and follow the algorithm, the first thing we do is see if the patient has clinical cardiovascular disease or a 10-year risk calculated at 10% or greater by the pooled cohort equations. So if they're at high risk for heart disease or they have heart disease, then the recommendation is to treat with medications if they're unable to reach blood pressure goal. If you're not clinical CVD or 10-year risk is less than 10%, then you don't get treated unless you're at stage 2 hypertension with medications. Of course, lifestyle is always recommended for elevated blood pressure. And the big trial that informs this is the SPRINT trial. This study included patients who were at high risk for cardiovascular disease or had prior cardiovascular disease. The exclusion criteria are listed here, but notably they excluded people with diabetes. And in the trial, people were seen monthly to reach a target of 120 or 140. And they got pretty close. So the standard treatment, the goal was less than 120. They achieved a blood pressure of 121 on average. In the intensive treatment arm, and in the standard treatment arm, they were at 136 millimeters of mercury. So about a 15-point difference through 5 years of follow-up. And the trial was remarkably positive, a 25% relative risk reduction in the composite cardiovascular disease outcome, with curves continuing to separate over time, showing cumulative benefit of more intensive treatment, and a corresponding reduction in all-cause mortality, which is increasingly rare in cardiovascular outcomes trials these days. Importantly, too, blood pressure lowering was safe. So no difference in the rate of serious adverse events, And importantly, although not statistically significant, the intensive treatment arm actually had a higher rate of syncope than in the standard.
Sorry for the technical difficulties here. We'll restart, this taping of the presentation by Mary Navarre. So hang in there for us.
Thank you for the opportunity to present. For the next 10 minutes, we'll be talking about hypertension management and whether 130 is really the new 140. I put this talk together while at Duke, but recently transitioned to UT Southwestern. These are my disclosures. So I think the shortest answer to this question really comes from a review of the most recent guidelines. And I really liked this ACC document, Guidelines Made Simple, which sort of goes through the 2017 guideline and breaks it down into sort of more digestible bites. And if we look at this table, one of the things that the recent guideline did that was really revolutionary is they redefined hypertension. So we used to say hypertension started at 140 and you were pre-hypertensive below that, but now we actually categorize stage 1 hypertension as 130 to 139 systolic and 80 to 89 diastolic, with stage 2 hypertension of 140 over 90. And then what the guideline did is kind of broke down treatment by stages of hypertension. So what we're talking about today is this sort of 130 to 139 cutoff. And here, the short answer is 130 the new 140 is it depends on who you are. So if we look and follow the algorithm, the first thing we do is see if the patient has clinical cardiovascular disease or a 10-year risk calculated at 10% or greater by the pooled cohort equations. So if they're at high risk for heart disease or they have heart disease, then the recommendation is to treat with medications if they're unable to reach blood pressure goal. If you're not clinical CVD or 10-year risk is less than 10%, then you don't get treated unless you're at stage 2 hypertension with medications. Of course, lifestyle is always recommended for elevated blood pressure. And the big trial that informs this is the SPRINT trial. This study included patients who were at high risk for cardiovascular disease or had prior cardiovascular disease. The exclusion criteria are listed here, but notably they excluded people with diabetes. And in the trial, people were seen monthly to reach a target of 120 or 140. And they got pretty close. So the standard treatment, the goal was less than 120. They achieved a blood pressure of 121 on average. In the intensive treatment arm. And in the standard treatment arm, they were at 136 millimeters of mercury. So about a 15-point difference through 5 years of follow-up. And the trial was remarkably positive, a 25% relative risk reduction in the composite cardiovascular disease outcome, with curves continuing to separate over time, showing cumulative benefit of more intensive treatment, and a corresponding reduction in all-cause mortality, which is increasingly rare in cardiovascular outcomes trials these days. Importantly, too, blood pressure lowering was safe, so no difference in the rate of serious adverse events. And importantly, although not statistically significant, the intensive treatment arm actually had a higher rate of syncope than in the standard treatment arm. And if we put this together as a meta-analysis of all randomized trials that looked at more intensive, or that looked at blood pressure lowering, we can see that the baseline blood pressure that you have really does not affect the benefit of blood pressure lowering. So this graph is a meta-analysis of a bunch of different studies, thousands of patients, including SPRINT patients, and looking what your baseline blood pressure was, and then what was the hazard rate or the relative risk reduction for blood pressure lowering standardized per 10 millimeters mercury. And although this point estimate actually looks most significant in the less than 130 category in terms of the clinical magnitude, it's actually a pretty wide confidence interval. And essentially what we see is regardless of your baseline blood pressure, even if you're in the 130s, you benefit from blood pressure lowering. So why 130 instead of 120 as studied in SPRINT? Well, the short answer here is because the way that blood pressure is measured in trials is not the same as what we get in clinical practice. Almost every blood pressure trial, not just Sprint, makes people wait a full 5 minutes, sometimes up to 15 minutes, and then usually takes multiple readings and averages those readings. Lots of other studies have shown that if you actually do that in clinic, you're going to get about up to a 10-point difference in blood pressure if you make them wait and then repeat. So the general consensus was that a blood pressure of 120 in Sprint was about 130 with what we get in clinical practice. So what about diabetes? Didn't tell you specifically, but in the guideline, we treat patients with diabetes the same as those without. This is an area where the data are actually a little bit fuzzier. The biggest study to look at intensive blood pressure lowering in diabetes was the Accord trial. This randomized people with diabetes to a target of less than 120 versus less than 140. The median follow-up was 4.7 years. They had 4,700 patients. And they achieved a blood pressure of 119 in the intensive arm and 133 in the control arm. And here you can see the primary outcome curves almost overlapping, really no difference in the primary composite endpoint or any of the individual composites over time when more intensive blood pressure targets are used in diabetes. Now, some people have said that maybe one of the reasons why Accord was not positive was the lower than expected event rate in the trial, and also that the standard treatment arm actually did pretty well with a blood pressure, I guess, closer to 130 than 140. My interpretation of this, though, is we did see a 14-point separation of blood pressure over time, and so it was sort of surprising in light of the Sprint results that when you look at Accord, we don't see a similar separation. But Accord isn't the only study that's looked at blood pressure in people with diabetes, and in fact, if we take pooled data from all blood pressure lowering trials and those with diabetes, all-cause mortality and stroke do seem to be improved with a more intensive target. So this is data from a meta-analysis. The top in gray shows a pooled hazard ratio of about 0.87 for targeting a blood pressure less than 135. It's 0.9 if you target a blood pressure of less than 130. That's not statistically significantly different. So attenuated compared to what we saw in Sprint, but is reduced. A little bit stronger data for more intensive blood pressure lowering and stroke reduction when we pool those data together. So ultimately, the guidelines recommend that we treat people with diabetes the same with a blood pressure goal of 130/80 as a trigger to initiate or up-titrate pharmacologic treatment. And then finally, let's end on risk. So why does risk matter? Why are we calculating 10-year risk to decide who gets treated and who doesn't? Well, probably the best data for how to think about risk and blood pressure comes from the HOPE-3 trial. So prior to HOPE-3, there really isn't that much data in blood pressure lowering in people who are at intermediate risk of blood pressure, of heart disease. That's actually even less data in those who are at low risk of heart disease. So HOPE-3 was a 2x2 factorial design study that had a blood pressure arm and a lipid arm. In the blood pressure arm, the baseline blood pressure was 138/82 on average. So this is sort of, under the old paradigm, they would have just been under the target. And the question is, do we need to up-titrate them or not? Only 22% were on blood pressure meds at baseline. So sort of a mix of some people who are treated just below 140 and some people who may not have been thought to be high enough to initiate therapy. And they were randomized in the blood pressure arm to a combination of candesartan and hydrochlorothiazide. And that was compared with placebo. Importantly, those in the study could not have an indication for an ACE inhibitor or prior cardiovascular disease, so truly intermediate risk. There was a difference in blood pressure in the treatment versus placebo arm, although the difference was not as striking as we saw in Sprint or Accord. The blood pressure drop was 10 points in the treated arm and 4 points in the placebo arm, so a difference of about 6. And the diastolic had a difference of about 3 millimeters of mercury. But again, there was a separation in blood pressures, and it was sustained over the course of the study. And overall, you see in this box shows the overall hazard ratio, and then the hazard ratio for the treatment compared with placebo stratified by baseline blood pressure. And we see that overall, there was no statistically significant benefit. The hazard ratio was 0.93, which very much overlapped 1 for its confidence interval. So it did not improve outcomes in intermediate risk patients. However, in a pre-specified subgroup analysis, those who are in the top tertile of baseline blood pressure, so those over 143, did have a 27% reduction in cardiovascular events by treating their blood pressure. So, and that was only with achieving a difference of blood pressure of 6 points. So treating people at intermediate risk who are over 140 works, and it lowers cardiovascular events. But HOPE-3 does not support that we should be treating people whose blood pressures are in the 130s or certainly below 130 if you're at intermediate risk. I do want to point out, though, that if you have another indication for blood pressure medication, for example, you have diabetes or chronic kidney disease with albuminuria, then the benefit of ACE inhibitors, for example, in preventing the microvascular disease is independent of blood pressure. So don't forget that some of your patients may need blood pressure medications for other indications, even if their blood pressure is within range. So we look at the guidelines, again, just to sort of wrap it up. The question of whether 130 is the new 140 really depends on whether or not you are a no or a yes in this particular little diamond. So if you have clinical cardiovascular disease or predicted risk greater than 10%, the answer is yes, and you should have your medications up titrated to get to a goal of less than 130 systolic and less than 80 diastolic. Thank you for your time. I appreciate all of your attention, and I wish you all the best.
Very much, Dr. Navar, and sorry for the technical glitch. Obviously, we have one more presentation for this session this morning, which is an important presentation about intensive cardiac rehabilitation, an underutilized resource, and I can vouch for that, actually. Over the past few years, we've done amazing rehabilitation for our rehabilitation, and now I'm very happy to say that the vast majority of patients get rehabilitation, and I think this is an underutilized resource. So for that will be Dr. Pam Taub, and Dr. Taub is Associate Professor of Medicine at UC San Diego in Loyola, and she's the Director of the Step Family Foundation Cardiovascular Rehabilitation and Wellness Program. Dr. Taub.
Well, it's great to be here today and to talk to you about intensive cardiac rehabilitation, which is often an underutilized resource. I'm Pam Taub. I'm a cardiologist at UC San Diego and the director of our Cardiac Rehab and Wellness Center. I'm going to first start by reviewing intensive cardiac rehabilitation because this is not a program that is known to many. It's many ways a new paradigm. Then I'll briefly review outcomes associated with intensive cardiac rehab, and then some of the challenges with intensive cardiac rehab, both in the COVID era and in the pre-COVID era. So when we talk about cardiac rehabilitation, most people think about traditional cardiac rehabilitation, which is really exercise delivered as 36 sessions over 12 weeks. Intensive cardiac rehabilitation allows you to do 72 sessions, and it can be delivered in multiple ways. At UC San Diego, we participate in the Ornish program, which concentrates the sessions into 9 weeks, and it's delivered in 4-hour increments. So patients come in twice a week and for 4 hours each time. The first hour is the exercise, which is very similar to what is done in traditional cardiac rehabilitation. This is followed by an hour of nutrition education, which often encompasses making a meal and consuming a meal. And the meal really teaches patients about healthy eating. This is followed by another hour of stress management, and this delivered by many modalities such as yoga or Tai Chi. And the 4th hour is a group support session. You'll see that the coverage for both traditional and intensive cardiac rehabilitation is very similar. Patients who basically have had an event, have chronic stable angina, cardiac surgery are all eligible. Traditional cardiac rehabilitation is limited to patients with peripheral arterial disease. Systolic heart failure now is starting to get covered in intensive cardiac rehabilitation. Diastolic heart failure or heart failure with preserved ejection fraction still does not have coverage for both traditional and intensive cardiac rehabilitation. These are the two main programs under which intensive cardiac rehabilitation can be delivered. These are the programs that you have to utilize to get reimbursed by providers, especially Medicare. I briefly mentioned the orange. Well, it's great to be here today and to talk to you about intensive cardiac rehabilitation, which is often an underutilized resource. I'm Pam Taub. I'm a cardiologist at UC San Diego and the director of our Cardiac Rehab and Wellness Center. I'm going to first start by reviewing intensive cardiac rehabilitation because this is not a program that is known to many. It's many ways a new paradigm. Then I'll briefly review outcomes associated with intensive cardiac rehab, and then some of the challenges with intensive cardiac rehab, both in the COVID era and in the pre-COVID era. So when we talk about cardiac rehabilitation, most people think about traditional cardiac rehabilitation, which is really exercise delivered as 36 sessions over 12 weeks. Intensive cardiac rehabilitation allows you to do 72 sessions, and it can be delivered in multiple ways. At UC San Diego, we participate in the Ornish program, which concentrates the sessions into 9 weeks, and it's delivered in 4-hour increments. So patients come in twice a week and for 4 hours each time. The first hour is the exercise, which is very similar to what is done in traditional cardiac rehabilitation. This is followed by an hour of nutrition education, which often encompasses making a meal and consuming a meal. And the meal really teaches patients about healthy eating. This is followed by another hour of stress management, and this delivered by many modalities such as yoga or Tai Chi. And the fourth hour is a group support session. You'll see that the coverage for both traditional and intensive cardiac rehabilitation is very similar. Patients who basically have had an event, have chronic stable angina, cardiac surgery are all eligible. Traditional cardiac rehabilitation is limited to patients with peripheral arterial disease. Systolic heart failure now is starting to get covered in intensive cardiac rehabilitation. Diastolic heart failure or heart failure with preserved ejection fraction still does not have coverage for both traditional and intensive cardiac rehabilitation. These are the two main programs under which intensive cardiac rehabilitation can be delivered. These are the programs that you have to utilize to get reimbursed by providers, especially Medicare. I briefly mentioned the Ornish program that we do at UC San Diego. There is also the Pritikin program, which allows for 72 sessions that can be customized based on a patient's schedule versus Ornish, where we really have them come in twice a week, 4 hours each time. There is a little bit more leniency with the Pritikin in terms of diet. It does allow for lean meat and fish, and some parts of the Pritikin program are delivered through video instruction, which is very timely in the era of COVID-19. One of the issues with intensive cardiac rehabilitation is there is a big upfront cost in starting these programs. And so a lot of the smaller centers and private practices are not able to invest in that startup cost and some of the infrastructure that is associated with delivering these programs. We all know that cardiac rehabilitation is associated with incredible outcomes. Study after study has shown that when patients engage in cardiac rehabilitation, there is a reduction in mortality and readmission rates. And it is a Class 1A recommendation by the AHA-ACC. This is an example of some of the infrastructure that we are lucky to have to deliver a program like this. This is our teaching kitchen where we cook meals for the patients and the patients consume these meals during their session. This is an example of a cohort. Prior to COVID-19, we were having groups of 10 to 16 in each cohort. And one advantage of having a cohort is these groups come together and they really form lasting relationships after the program. We've seen in many studies of intensive cardiac rehabilitation that there's improvements in biomarkers and in other parameters, such as here in the coronary artery diameter after patients are put on an intensive lifestyle program. Here is another example of a patient from the program. And what you see is the only intervention that was done between June and September was enrollment in the intensive cardiac rehabilitation program. And what you see is an increase in the coronary artery diameter. This is an important concept because patients are often thought to believe that the only thing that can reverse coronary disease is medications and procedures. And this is an example of how lifestyle intervention can reverse coronary disease. We decided to do a study at UC San Diego to really quantify some of the differences between intensive cardiac rehab and traditional cardiac rehabilitation. So in this study, we looked at our last 317 patients that went through our programs, and 216 were in our traditional program and 101 were in the intensive cardiac program. And what you see is in the intensive program, in the coronary artery diameter after patients are put on an intensive lifestyle program. Here is another example of a patient from the program. And what you see is the only intervention that was done between June and September was enrollment in the intensive cardiac rehabilitation program. And what you see is an increase in the coronary artery diameter. This is an important concept because patients are often thought to believe that the only thing that can reverse coronary disease is medications and procedures. And this is an example of how lifestyle intervention can reverse coronary disease. We decided to do a study at UC San Diego to really quantify some of the differences between intensive cardiac rehab and traditional cardiac rehabilitation. So in this study, we looked at our last 317 patients that went through our programs, and 216 were in our traditional program and 101 were in the intensive cardiac program. And what you see is in the intensive program, the adherence is much higher, and that's likely because of a cohort effect. And in terms of patient demographics, very similar in terms of age and gender and who was enrolled in intensive cardiac or traditional cardiac rehab. But what we saw is when patients engaged in the intensive cardiac rehab program, they had much more significant benefit in terms of BMI and body weight and waist circumference. And here you can see that that's statistically significant between the intensive cardiac program and the traditional program. We also saw changes in body fat that were more significant with intensive cardiac rehab. Visceral fat decreased in both programs, and LDL cholesterol was decreased with both programs. So in summary, we did see some benefits with intensive cardiac rehab over traditional cardiac rehab in the realms of metabolic biomarkers such as weight, BMI, and certain hemodynamic parameters such as blood pressure, and in lipid biomarkers like LDL cholesterol. So why isn't intensive cardiac rehabilitation utilized more? Well, as I mentioned earlier, there is that upfront cost that's associated with setting up these programs. The other issue that's now emerged during the era of COVID-19 is that many of these intensive cardiac program activities involve group sessions. And we are very limited in the number of patients that we can have in a group because we want to have social distancing, we want to minimize virus spread. So that also limits the implementation of intensive cardiac rehabilitation during this COVID-19 pandemic. And when you have smaller cohort sizes, it really decreases the financial viability of the program. You really need to have at least groups of 12 or more to make this program viable for your institution. So COVID-19 has limited intensive cardiac rehab implementation. However, as everyone is trying to adopt and evolve their programs, one thing that has been tried is some virtual offerings for the intensive cardiac program. So for instance, delivering the stress management through a virtual format. So these are all things that are evolving, but again, a challenge during the COVID-19 pandemic. So in summary, lifestyle approaches such as cardiac rehabilitation reduce cardiovascular risk. In our small study at UC San Diego, we have shown that intensive cardiac rehabilitation has a more potent risk reduction compared to traditional cardiac rehabilitation in certain metabolic and hemodynamic parameters. We find that the strategies that are utilized in intensive and traditional cardiac rehabilitation are very synergistic with our current device and pharmacotherapy. And we really need to be thinking about intensive cardiac rehabilitation as a powerful way to deliver cardiac rehabilitation, but we need to figure out strategies to
Dr. Top, can you hear us? Seems
She's smiling at least.
okay. And it seems like you may be getting the signal now.
Yes.
Excellent, excellent. Okay, so the question really one is that you pointed out either the Pritkins or the Ornish. Are there any other options that we can explore? Nowadays, there is a considerable interest in the plant-based or the keto diets.
Well, for patients who are undergoing cardiac rehab, who qualify for cardiac rehab based on conditions such as coronary disease, cardiac surgery, the two real options are Ornish and Pritikin. There is a program that Mass General started called the Benson program, but that's not widely available. And to get reimbursement through insurance, you have to go through these two programs. You mentioned the ketogenic diet. There's a lot of controversies about that diet. It involves very high fat in foods, and we don't recommend that for our patients with coronary disease. It's often used for short-term weight loss in our younger patients and under very specific circumstances. So unfortunately, we are it is a little bit of a monopoly right now in intensive cardiac rehab with Ornish and Pritikin. There are many places that are trying to get their specific program approved through Medicare, but so far, those are the only two options.
Thank you so much. One quick question. Also, in the COVID era, are you advocating or your program moved to more telehealth resources, especially dedicated to cardiac rehab?
Yes. So COVID has really catapulted telehealth to the forefront in so many ways. And here is an example of where we should have been doing remote cardiac rehab to make cardiac rehab more accessible for our patients, but we just never did because of the reimbursement. And now with COVID, we've been forced to do it. And one of the things that we're doing, which has worked out very well, is a hybrid program where they come in for maybe their initial evaluation to the center, and we really make sure that they're safe to exercise. And after that initial session, then their other sessions are through video. And then they can choose if they want to check in once a month or once every 6 weeks with our center. So I find that program is that structure is really well received, because there is a little bit of feedback that's live, and yet they're able to do a significant portion of the program from their home.
And maybe a question about hypertension. I know there were a lot of chat about hypertension and age and greater than 70 years of age. Any modulators that you would consider, besides just the number of blood pressure, modulators that you would see? Obviously, somebody has to be tolerating the medication, no question about it. But a lower risk individual, besides hypertension, if everything else is okay, does that modulate your approach? You have to
put it in the chat box, but for those who may not be reading along.
Yes, exactly.
A big change in the guidelines was that we dropped, the last set of hypertension guidelines recommended 150 as the systolic blood pressure target in older adults. And that was largely based on data from Japan, and there wasn't a lot of data in sort of a contemporary era in older adults. So because the SPRINT study had so many older adults in it, and the impact in terms of reducing events was so compelling, even in those older adults, there was that recommendation went away, and now we treat older adults the same. In fact, older adults at higher risk are recommended to have a blood pressure of less than 130/80. Really important to remind everybody that there was no increased risk of syncope, no increased risk of falls, no increased risk of fractures, so very safe to treat our older adults. Now, you did ask what modulates that. So do we treat every single older adult to 130/80? No. And even the guidelines themselves, after recommending 130/80, do include a caveat that this involves shared decision making with patients. We want to look at their overall prognosis, thinking about issues of polypharmacy and multimorbidity and side effects are all really, really important. I think that what we see in terms of observational data, there tends to be, providers tend to be more inclined to undertreat older adults. And if we talk to a lot of older adults, many of them are as motivated to avoid strokes and heart attacks as the rest of us, and may be actually interested in more aggressive blood pressure lowering, particularly if they know that it's safe. So obviously we do care about shared decision making. We pay attention to patients' preferences, but I think any older person that's higher risk, I would start with a 130/80 target, and then really have to have a really compelling reason why I would adjust that in somebody who's older. One more caveat, I know this is a long answer, but it's important. Any carotid stenosis or major vascular impairment to cerebral blood flow does matter. So making sure that we have a good understanding of peripheral arterial disease, thinking about carotid stenosis or other major macrovascular stenoses and intracranial stenoses that the brain may be seeing a lower blood pressure would be another group that you would maybe not go that low in.
That's great.
That's great. So this is a question for Dr. Khan and Dr. Shapiro combined, is preventive cardiology, mainly over the last decade or even before, has been focusing on prevention of ACVD. Now this whole new tools are upcoming with heart failure. So what would preventive cardiology clinics needs to do to ensure that we can do more appropriate heart failure screening and then risk screening, and then where the focus needs to be? Is it going to be more lifestyle? Of course, lifestyles for everyone, but are we moving towards heart failure, blood pressure medication, or as you pointed out, maybe the SGLT2 inhibitors are going to be the new statins?
Thanks for that question. I think from a heart failure perspective, we just want to think about the same risk factors that we're managing in ASCVD. And the difference here is, can we be doing any additional screening that really helps understand what the subclinical risks may be, or is there end organ damage? So we were talking a little bit in the chat about handheld echo and other tools that potentially could be more widespread. The biggest limitation to doing more community surveillance screening with echocardiography has been cost and availability to make that more widespread. And I think that's really why that STOP-HF study started with biomarker-based screening. So BNP is readily available, and we usually defer until somebody has symptoms to try to use it for diagnostic purposes, but could it be used earlier and upstream once people have risk factors? And I think the 2017 guidelines did a really nice and compelling job of saying that this could be very helpful. But it's not perfect, and I think that's where, as the evidence accumulates, thinking about other risk factors, other biomarkers, and imaging will really help broaden that, but I don't think we're quite there yet for clinical practice.
Maybe a question to Salim, Michael, and actually all of you. In the guidelines currently, number one, are we missing anything that may be really important upcoming that hopefully should be addressed in the next version? So that's one. I want you to think about that. Two, what are you guys working on to bring to the fore maybe a class 1 indication? Is there something that you would wish has a stronger indication or a stronger approach? Because I think that what pushes not only awareness, but pushes the research for us to have the evidence to be able to do this.
If you want, I can start out and leave a few things for Michael and Sadia to address as well. I'll talk about the risk stratification piece. Right now, if we look at the 10-year risk estimation, we really are only picking up atherosclerotic cardiovascular disease events. Now, the blood pressure guidelines, as Anne-Marie very, very clearly showed, even they are risk-based. But if you look at the events that it's picking up, it's atherosclerotic cardiovascular disease events, whereas for hypertension, it's really heart failure. So I think we need some risk stratification tools that are picking up global CVD rather than just atherosclerotic cardiovascular disease events. So that's one thing that I think is something that's lacking in our risk stratification schema that we need to work on. The other is that social determinants of health are not incorporated into our risk stratification scheme. We know that going by US zip codes, we get probably even a little bit better fit when we look at cardiovascular disease events compared to our traditional risk factors. And some of these schemes in UK use those. How do we bring those into our risk stratification schemes as well? I think those are two important things as far as the risk stratification piece is concerned, that I think will be important going forward and looking at cardiovascular disease from a global perspective, both in terms of outcomes we are assessing, but also from a patient's perspective as to what are the determinants of cardiovascular risk and cardiovascular health. And then I'll leave the others for Sadia and Michael to answer, and I have a few thoughts.
Michael, I'd like to hear from you.
Yeah, certainly. Thank you for the question, and I completely agree with Salim. I mean, there's a lot of potential answers to this question, but one thing that weighs on me heavily in what I think may be the next frontier in preventive cardiology is really trying to understand the drivers of risk in any given individual patient. As I mentioned, we've focused on LDL for the last decades, and that's been a successful approach. But as we see, we can functionally eliminate LDL, and there's still plenty of residual risk in many patients. So if you have a monogenic disorder like familial hypercholesterolemia, and LDL is driving all that risk, then the simple solution is controlling LDL. But in the vast majority of people who are at atherosclerotic disease risk, there's multiple drivers of risk, and trying to understand principal drivers of risk in any given individual patient has remained challenging. I think in oncology, they're way ahead of us. They've been using imaging, genetics, biomarkers to tailor therapy, and that's really where we need to go to sort of manage residual risk of cardiovascular disease.
Beautiful.
I'll just tag on to that. I think the other piece of this that is really challenging from a prevention standpoint is the patient-facing side. And so you speak about how oncology is so far ahead of us, but the majority of people still think cancer is their biggest threat. And so when we start talking about cancer, there's a much more willingness to do more things because of the fear associated with that. But I think that's a big challenge, especially in heart failure, because people don't understand what it is. And so when you start to talk to people about preventing heart failure and why it's important, it's really hard to get that point across. So I think that risk communication piece is another place where there's a lot of work to do from the implementation side.
This is, I think, very important. And let me tell you also, there is a misperception from a patient's perspective that a stent, a PCI, is curative. And I think we really have to do better at education from that aspect point of view, that yes, we have tools in the toolbox to address acute situations, but this is really what doesn't prevent a heart attack and a stroke. So
I just have to add one group that I think we probably have to think about and probably need more work to do in the future, which is young people with high lifetime risk but low 10-year risk, particularly women or younger people with high LDL cholesterol. So right now we have a 1A recommendation if your LDL is over 190. There's a consider recommendation if your LDL is 160 or above. But a lot of young people are not getting treated that have high LDLs, which is really a cumulative toxic exposure to the arteries, and they're not being treated by the guidelines, and part of that is a lack of data on what to do. We do know that our current guidelines miss a large proportion of people who develop premature coronary artery disease because so much of the risk calculators are based on events that happen in older adults. So there's work to do there, and I'm really excited about some of the work that the panelists are doing on CAC scoring and coronary CT scans to help us better risk stratify and identify who needs treatment earlier in life.
Well, with that, I think we cannot thank you enough. I think faculty has been amazing this morning for our first introductory session on cardiovascular prevention. Sorry for the glitches. I think hopefully with our second segment, things are better. The internet maybe is warming up here in Houston, so we could do that. And I want to thank, obviously, our audience to be here with us this morning. So with that, thank you. And we'll hand it over to session number 2, which I love the title. Men are from Mars and women are from Venus. And to chair that is my colleague, Dr. Carla Kermeyer. Carla is the director of our cardiovascular clinic. Her certainly interest is women heart disease. Carla, it's great to have you today.
Thank you very much, Dr. Zogby. I'm very excited about this next set of talks. As Dr. Zogby said, we're switching gears a little bit, and we're going to focus on prevention of cardiovascular disease in women. Our first speaker is coming to us from Phoenix, Arizona, Martha Galati, and she is the division chief there at the University of Arizona College of Medicine, and I'm very excited to hear her talk. The title of her talk is Yentis Bikini, How to Reconcile Sex Differences in Cardiovascular Disease Prevention. Good morning, Martha.
So thank you for having me, and I am going to be talking about sex differences in outcomes from COVID-19. It's great to be here, and thank you for the attention to this topic. I'm going to talk about sex disaggregate data from COVID-19 and also discuss the association of cardiovascular disease and risk factors with COVID-19, and talk a little bit about implications of cardiovascular preventive care now that we learned some lessons from COVID-19. So if you think about it from the spectrum of preventive,
move beyond the bikini to protect a woman's heart because we still haven't made enough headway in terms of heart disease. Why does it matter? Why should Hello, my name is Dr. Martha Galati. I'm the editor-in-chief for CardioSmart for the American College of Cardiology, and I am going to be talking on Yentl's bikini, how to reconcile sex differences in cardiovascular disease prevention. I have no disclosures. So, cardiovascular disease remains the number one killer of men and women in the United States. But at the time, we were seeing great declines in cardiovascular disease mortality in men. We were not seeing the same declines in women. It wasn't really until the last decade and a half that we started seeing reductions in mortality. Around 2001, we started seeing a reduction in mortality. And at that time, we had important studies that included women. We had guidelines that included women. And we had the beginning of the Go Red movement. Nonetheless, heart disease remains the number one killer of men and women. And for women, it accounts for over 400,000 deaths. If you think about breast cancer, which women often think is the leading killer, it's actually the fourth leading cause of death. In terms of prevalence, if you think about this, 60 million women in the United States live with some form of cardiovascular disease, including hypertension, which is essentially 1 in 2 women. This is in contrast to the 3.5 million women that live with breast cancer. The most concerning trend, though, for us has been in the last few years, where we actually are now seeing an increase in cardiovascular disease mortality. And it's particularly noteworthy that it's our younger population that is more likely to die from cardiovascular disease. So when we talk about Yentl syndrome, Yentl was actually a story about a woman who had to disguise herself as a man in order to be taken seriously. She wanted to study the Talmud, and she had to disguise herself as a man because a woman wasn't allowed to study the Talmud in that time. So Dr. Bernadine Healy, the first woman to head up the National Institute of Health, coined this term saying that, do women have to be exactly like men in order to be taken seriously? Why were we excluding women in trials? Did we assume that women were exactly like men? And this assumption that only if we present exactly like men will we be taken seriously. But there's many differences in women compared to men. And the idea about the bikini approach to women's health, this idea really came from Dr. Nanette Wenger. And she said that the medical community has really viewed women's health with a bikini approach, essentially looking at the breasts and the reproductive system and ignoring the rest of a woman when we talk about women's health. And she said that many years ago, but even more recently, I asked the question of how are we going to move beyond the bikini to protect a woman's heart? Because we still haven't made enough headway in terms of heart disease. Why does it matter? Why should we study women? Why should we know these differences? Well, sex matters. Sex is biologically determined, and every cell has a sex, and every molecule is influenced by sex in our body. So it's important to know the biological differences between men and women, XX versus XY. That's not to minimize the effect of gender, because certainly gender has an important influence on our health as well. It plays a role in how social and environmental factors influence our health, and also influences lifestyle and behavior choices. So both matter, but the biological differences are things that we must understand in terms of how medications are metabolized, how risk factors affect a woman compared with a man. So when we talk about the traditional ASCD risk factors, it's important to note that there are some sex differences. Just quickly to look at this table of the traditional risk factors. Smoking, although there's less women that smoke in the United States, if they smoke the same number of cigarettes, the vascular effects are actually greater in women compared to men. Diabetes is more prevalent in women compared to men, and the relative risk for cardiovascular disease is greater. Hypertension as well, there's a greater risk of cardiovascular disease in women. There is disease states like lupus and rheumatoid arthritis that are more prevalent in women. Almost 80% of the people affected by these diseases are women, but we right now don't know if there is an increased risk for women compared with men in terms of the cardiovascular effects. There's also sex-specific issues for women, things that only can happen to women because only women can get pregnant. So we'll talk about those, and you'll hear about that in a talk that will come up later. But let me just highlight one traditional risk factor that we think think we know well, and that's blood pressure. We know blood pressure, elevated blood pressure can increase the risk of cardiovascular disease. But in a recent paper from earlier this year, we saw that actually the trajectory of incline of systolic blood pressure over a lifetime for a woman is greater than it is for men. And it's not really dimorphic. We used to think that, okay, at menopause, blood pressure increased in women, but this does not seem to be the case based on this population study. So we need to really study women so that we know what happens. And this very elegant study portrays a traditional risk factor that we had thought we understood quite well, and maybe we do not. We also need to incorporate sex into the traditional risk scores. And when you calculate the ASCVD risk score, you do get to check off whether they're male or female and their traditional risk scores within here. This has certainly been well validated, but it doesn't take into account the sex differences aside from being able to choose male or female. But this is the starting point, and it does give us our 10-year risk as well as a lifetime risk, and it's a way to start, but it isn't the end. We need to assess the risk enhancers, things that are sex specific or sex predominant. And I'm going to have to go through these quite quickly, but you're going to hear about these in later talks. There's things that happen in pregnancy that we must note when we're assessing cardiovascular risk. Pregnancy seems to be nature's free stress test, and it effectively identifies women who would benefit from primary prevention efforts to reduce ASCVD risk. You're going to hear about this a little bit after me, probably the talk right after me, but especially the first 4 adverse pregnancy outcomes: preterm delivery, gestational diabetes, gestational hypertension or preeclampsia or eclampsia, and fetal growth restrictions are things that can occur during pregnancy and should be noted when you're assessing ASCVD risk. The most important thing is that 80% of women in the United States bear at least 1 child, and about 1 in 3 of them have adverse pregnancy outcomes. Other sex-specific issues that need to be taken into account: age of first birth, those adverse pregnancy outcomes, as I already touched on, fertility therapy, and particularly failed fertility therapy is something that should be noted. The age of menarche, because both early and late menarche have been shown to increase cardiovascular risk, polycystic ovarian syndrome, also functional hypothalamic amenorrhea, premature menopause, and premature ovarian insufficiency. Again, all are different and defined differently, but all have been shown to increase cardiovascular disease risk. If they're on the birth control pill, it's important to take that into account, especially if they smoke, and if they use hormone replacement therapy should be noted in their history. There's also the relationship between breast cancer and heart disease, and although women are more likely to survive a diagnosis of breast cancer since we have such excellent therapies now, it should be noted that some of the most common risk factors for breast cancer are also risk factors for heart disease. And additionally, the therapies that we use for breast cancer accelerate the risk for cardiovascular disease. So it's important to ask about whether they got radiation therapy and what type of chemotherapy they got. Doxorubicin and adriamycin medications that they can receive during chemotherapy are the ones that we're most interested in and that may accelerate their risk. And then, of course, some of their maintenance therapies like Herceptin can increase cardiovascular risk. So it's important to get that history from our patients and to discuss that they're at a much greater risk of dying from heart disease after they've done their therapy than actually breast cancer. So when you think about the breast, also think about the heart. So my approach is simply this. I start with the ASCVD risk score and take into account the traditional risk factors. Then I take an inventory of their sex-specific factors as well as their female predominant conditions. Both of these are important and a way for us to personalize our care for our patients. If we don't ask about sex, I'm not sure what other genetic tests are going to help us. So I hope that you understand that precision medicine requires the consideration of biological sex. Take into account the traditional risk factors and note that there's differences in how they impact women compared to men. Then take into account sex-specific ASCVD risk factors as well as sex-predominant risk factors. These considerations in women's health are important because we have to move beyond the bikini, and particularly to the number one killer. Thank you for your attention.
That was a very enlightening talk. We're going to save the questions till later, and we're going to go on to our next speaker, who is Nindita Scott, and she's coming to us from the Boston, Massachusetts, where she's the co-director of the Corrigan Women's Heart Health Program and co-director of the Cardiovascular Disease and Pregnancy Service. And she's going to talk to us about pregnancy in the heart and prevention starts from the womb. Welcome, Dr. Scott.
So thank you very much for inviting me to speak at this important symposium on pregnancy and the heart, an opportunity for cardiovascular disease prevention. So we all know that cardiovascular disease is the leading cause of death in women, and we've made great strides in improving awareness among physicians, healthcare providers, and patients. But I think the other piece of this is that there are many conditions that are unique or predominant in women, and women are not just little men. Pregnancy is an opportunity that provides a unique window into future heart health, so much so that multiple societies, including the American Heart Association, the European Society of Cardiology, and the ACOG, recommend that clinicians elicit an obstetric and gynecological history when assessing a woman's cardiovascular risk. Now, maternal mortality is rising in the US as it declines elsewhere. Maternal mortality is defined as death per 100,000 live births. And as you can see from this graph, it is increasing in the United States of America, and we have the worst maternal mortality than any other developed nation in the world. The reason I'm telling you this is that cardiologists really need to be part of the solution to reducing maternal mortality, because many of the causes or reasons why women die during pregnancy are cardiovascular mediated. So if you look at this graph, which shows us the causes of pregnancy-related death in the United States between 2011 and 2016, many of these are cardiovascular mediated, such as thrombotic pulmonary embolism, strokes, cardiomyopathies, and other cardiovascular conditions. I wanted to highlight hypertensive disorders of pregnancy, which causes approximately 7% of deaths of American women during pregnancy. So when I speak about hypertensive disorders in pregnancy, for the purpose of this talk, I'm grouping together essential hypertension patients who become pregnant, patients who develop gestational hypertension, patients with essential hypertension that go on to develop preeclampsia, and then preeclampsia as its own entity. Hypertensive disorders of pregnancy complicate up to 10% of pregnancies worldwide. It's one of the greatest causes of maternal and perinatal morbidity and mortality, and the incidence is increasing. Preeclampsia itself is responsible for 50 to 60,000 deaths worldwide, and there are many near misses that result in significant health risk and care costs to the mom and the babies. Now, once our women survive their pregnancy with hypertensive disorders of pregnancy, the risk is not diminished. This meta-analysis performed by Wu and colleagues looked at 22 studies with 258,000 women with preeclampsia, and they found an independent association between cardiovascular disease death, coronary heart disease death, heart failure, and stroke in women who developed hypersensitive disorder of pregnancy. This was true even after adjusting for age, body mass index, and diabetes. And the risk, as you can see here, is heightened within the first 10 years postpartum. So these are not our older women who are developing cardiovascular disease. These are women who are literally just 10 years out from their last birth. Our group, led by Drs. Natarajan and Honenberg, looked at this study, which was undertaken to answer several unresolved questions. What is the risk of hypertensive disorders of pregnancy, and does it extend beyond midlife? The other unanswered question is, what is the relationship between hypertensive disorders of pregnancy and non-atherosclerotic heart disease? This study used the patients from the UK Biobank, of which it was prospective observational. Women were aged 40 to 69. There were 222,000 women total, of which 2,808 had a hypertensive disorder of pregnancy. The mean age was 57.8, and the median follow-up was 7 years, but the mean duration since birth was 31 plus or minus 10 years. What they found was that there was an increased hazard ratio for coronary artery disease, heart failure, aortic stenosis, and mitral regurgitation. Now, this signal for increased risk of valvular disease is certainly very interesting and definitely a reason to do further research. Dr. Honenberg and Natarajan also looked at non-invasive arterial stiffness index that was available in approximately 1,190 patients. And they found that there was a higher arterial stiffness even after adjusting for body mass index, diabetes, and smoking in women with hypertensive disorders of pregnancy, but not after adjusting for hypertension. Using a causal mediation analysis, cardiovascular risk after hypertensive disorder of pregnancy was largely but incompletely mediated by hypertension. So what is it about hypertensive disorders of pregnancy, and why does it increase the risk of future cardiovascular disease? Does it unmask a pre-existing risk? Dr. Honenberg and Natarajan from our group also looked at genotypic and phenotypic data from the UK Biobank and found that in 2,770 people that had hypertensive disorders of pregnancy, and using a polygenic risk score, that there was a genetic predisposition to hypertension and elevated BMI that were associated with the development of a hypertensive disorders of pregnancy. On the other hand, is it an inciting event that triggers cardiovascular disease by the development of vascular and metabolic injury, by inflammation, endothelial dysfunction, insulin resistance, adiposity, etc.? This hypothesis is supported by the dose-dependent nature. So women who have early onset preeclampsia or hypertension during pregnancy do worse if they deliver preterm or develop it earlier versus the moms who have it at term. Other risk factors that increase cardiovascular risk during pregnancy are gestational diabetes, which is associated with a twofold future risk of cardiovascular disease, even without the interim development of type 2 diabetes, perhaps a signal again of cardiometabolic risk. This study shows the impact of preterm delivery and small for gestational age delivery. They followed patients for a median of 11.8 years. They adjusted for many things, including age, birth year, income, education, maternal country of birth, essential hypertension, diabetes, gestational hypertension, and looked at hypertensive disorders of pregnancy, and found the hazard ratio for coronary heart disease and cerebrovascular events were lowest in women who had term deliveries and a normal-sized baby, and worse for women who had a preterm delivery and a small baby, again showing a signal for increased cardiovascular risk. Dr. Parikh and colleagues looked at other reproductive risk factors, such as stillbirth, miscarriage, etc., and they actually found that stillbirth, miscarriage, young age at first birth, breastfeeding less than 1 month, they all related to the development of coronary heart disease. But there was a modest benefit over traditional risk factors. This data suggests that reproductive factors may be most useful in premenopausal women who, as we all know, based on the traditional Framingham, traditional risk factors, generally score low on risk. So what do we do with this information? So I'm going to offer you 5 potential opportunities where we can improve the cardiovascular risk assessment in these women. So first is preconception. For all of our patients, we should evaluate current cardiovascular conditions and risk for pregnancy. This includes women with valve disease, coronary artery disease, cardiomyopathies, and determine if they actually are at higher risk of pregnancy, whether their medications should be changed or optimized before they get pregnant. The first few weeks or the first trimester during pregnancy are very important for the formation of the placenta. So that's not a time where we want our women to have uncontrolled hypertension or be switching around their medications to try to find the right regimen that fits them at that point. This should be done preconception. We always want to encourage our women to have optimize their maternal health with perfect weight, heart healthy lifestyle. We need to determine who's at highest risk for pregnancy and counsel them and review birth control options, and identify those that may benefit from aspirin for preeclampsia prevention after 12 weeks gestation. So the U.S. Preventative Services Task Force has a grade B recommendation that for pregnant women who are at high risk for preeclampsia, they should start aspirin low dose, 81 milligrams a day after the first trimester. And the women with the highest risk are women with a history of preeclampsia, multifetal gestation, chronic hypertension, diabetics, renal disease, and autoimmune disease. And this can actually encompass a lot of women. If you have a moderate risk level, but you have several of these risk factors, you might want to consider aspirin for prevention of preeclampsia in this group as well. The second opportunity for prevention is postpartum. So there's really no evidence-based guidelines on how to guide postpartum follow-up after a pregnancy complicated by hypertension. Current expert recommendation is that follow-up should occur within 3 to 6 months after delivery. This is really challenging, though, if you don't have insurance. It's logistically challenging for new mothers who have newborns at home, and honestly, the last person they may be taking care of them is themselves. But it is also an opportunity to improve awareness in this population in moms with an adverse pregnancy outcome, as well as communicating with the primary care provider to make sure that they're aware of this increased risk and optimize this long term. So Dr. Graham Smith from Ontario, Canada, really spearheaded these maternal health clinics. And what they do there is that every woman with a pregnancy complication, such as preeclampsia, is seen in their clinic 6 months postpartum and advised on their risk, counseled, appropriate medications started, and communications relayed to their primary healthcare provider. This may not be feasible for the most vulnerable in our population due to loss of Medicaid at 60 days in many states. I was going to be giving this talk in Texas, and Texas is a non-Medicaid expansion state, so that women on Medicaid lose their health insurance after 60 days postpartum. How are we doing across the United States, though? This was a study done by Dr. Louie and colleagues at Penn that looked at women with hypertensive disorders and their attendance at a postpartum healthcare clinic to discuss their increased risk of a hypertensive disorder pregnancy and cardiovascular disease. And they found that women with hypertensive disorders of pregnancy are more likely than women with normohypertensive pregnancies to follow up with a provider. However, the follow-up rates were still extremely low. Only 58% of women did follow up. A fourth opportunity for us to improve risk opportunity in these patients is looking at the 2019 ACC-AHA guidelines on the primary prevention of cardiovascular disease. Now, in this guidelines, they actually addressed pregnancy variables as a risk enhancer. So if you have a woman who's an intermediate ASCVD risk, you look at the risk enhancers, and that would favor statin therapy. So the pregnancy variables that are now included are premature menopause and pregnancy-associated conditions such as preeclampsia. This is really an early opportunity to treat cardiovascular disease or target cardiovascular disease prevention in these at-risk women who historically their risk would be underappreciated using traditional risk factors and scores such as the Framingham risk model. And the last way that we can improve or have an opportunity to improve prevention in this group is to take history. So in our group, we ask every female patient, no matter what their age, we ask them their obstetric and gynecological history. So how many pregnancies have you had? Do you have infertility? So infertility has been shown to increase, potentially have a signal to increase cardiovascular risk. Have you had a lot of miscarriages? Did you deliver a term? Were your babies small when they delivered? And did you develop problems with blood pressure or blood sugar during pregnancy? And I think taking this simple few questions from history can help determine who might have an increased risk for future cardiovascular disease. So in conclusion, heart disease is a leading cause of death for women worldwide, including in our country. We need to include non-traditional risk factors when considering cardiovascular disease risk in women. And pregnancy offers a unique opportunity to gauge cardiovascular health. We can improve the care of our female patients by evaluating their risk pre and post conception, considering adverse pregnancy outcomes as a risk enhancer, and taking an obstetrical and gynecological history. Thank you very much.
Thank you, Dr. Scott. We're going to go right on to Dr. Sharma's talk. She's coming from us from Johns Hopkins University School of Medicine in Baltimore, and she is assistant professor of medicine there. And basically, she's going to talk about the sex differences and outcomes from the COVID-19 pandemic and implications for cardiovascular preventative care during recovery.
So thank you for having me, and I am going to be talking about sex differences in outcomes from COVID-19. It's great to be here, and thank you for the attention to this topic. I'm going to talk about sex disaggregate data from COVID-19 and also discuss the association of cardiovascular disease and risk factors with COVID-19, and talk a little bit about implications of cardiovascular preventive care now that we've learned some lessons from COVID-19. So if you think about it from the spectrum of preventative care, I think one thing is clear is that 60% of the deaths from COVID-19 occur in men. Also, patients that have underlying cardiovascular disease have about a 10-fold higher rate of having worse outcomes from COVID-19. So they're sort of interconnected. And so this may prove as an opportunity to advance preventive strategies and to engage men and women in reversing their cardiometabolic risks. We'll talk a little bit about the interplay of cardiovascular disease and COVID-19 and what the data is around that, but also use this as an opportunity to talk a little bit about redesigning preventive care and making it more patient-centered. So there are several risk factors that are associated with adverse outcomes, and in addition to advancing age or African-American race or minority ethnicity, comorbid conditions such as cardiovascular disease, chronic kidney disease, malignancy, and obesity. Male sex has evolved and really been seriously considered as a risk factor of having poor outcomes from COVID-19. And so this is important to recognize. And so if you do a deeper dive into comparative analysis of sex disaggregate data from many countries that are reporting it, it becomes clear, and we have 38 countries in here, it becomes clear that men have a much higher case fatality rate as compared to women. And on an average, the case fatality rate of men is about 1.7 times higher than of the women who get this disease. And also, if you break the data up into advancing age groups, it becomes very apparent that after the age of 40, the case fatality rate in men is consistently higher and in women than in women. And so this is important to know. And in terms of sex differences and hospitalizations, more than 50% of the hospitalized cases from all over the world are men. And in addition to that, most of the severe cases requiring ICU care or mechanical ventilation, prolonged intubation, and prolonged hospitalization are also men. And so the question is, why may that be? And, we'd like to break it down into a multifactorial approach. And there are several reasons or several possible reasons for it. One is the immunological differences in the sex. And we know that women patients seem to have a more intense, prolonged, innate humoral response as well as cell-mediated response and a faster and higher recognition of viral components. And so preclinical studies have shown that women might recover to a greater extent and are better protected from death from other viral illnesses. And does that say the same in COVID-19? There are also certain biological differences between men and women, between those two sexes, and it's important to recognize that. ACE2, which is the receptor, which is the cell membrane receptor where COVID-19 attaches itself and enters the cell, is an X-linked gene. And there have been a lot of reports about ACE2 level and ACE2 activity in both men and women. And we'll talk a little bit about that as well. But it's also important to know that estrogens are able to induce a downregulation of another protein, which helps it, attach COVID-19 to the cell. And it's TMPRSS2, which is a serine protease. And that is downregulated by estrogen and upregulated by androgens. In addition to that, some people believe that there's downregulation of ACE2 activity in women as well. And then the burden of cardiovascular risk as well as the cardiovascular risk factors. And so the extent and the prevalence of smoking, the prevalence of obesity, the prevalence of underlying chronic diseases such as hypertension, cardiovascular disease, and chronic disease. How does that interplay into worse outcomes from COVID-19? And lastly, high-risk behaviors such as less access to preventive care, less hand washing, less social distancing, and so on and so forth. And so we wrote about this in one of the papers commissioned by the Centers for Disease Control Preventive Chronic Disease Journal. And we focused on multi-pronged approach and trying to understand this, where biological, behavioral, social, and psychological factors were all possibly contributing to the case fatality rates. And so what we thought was men tend to downplay their symptoms and may actually delay access to care, which may potentially harm them. They also display more high-risk behavior, like less social distancing, less hand washing, less wearing masks, and avoiding large gatherings. And that also are possibly more involved in low-skilled, low-paid jobs that are the front line, such as food processors, transportation folks, as well as delivery and warehousing. And so that may expose them to COVID-19 as well. And so if you were to look at the results of what are some of the cardiovascular risk factors associated with COVID-19, this is data that came out in JAMA earlier that talked about 5,700 cases that were admitted to the hospital and required ICU hospitalization. What they found was the burden of cardiovascular risk factors was extremely high in this population. And in fact, if you looked at the folks, majority of them actually had more than one comorbidity. So these are patients that have an underlying cardiovascular risk factor. And so that really exposes them to worse outcomes. And so another piece of information that is very important is to recognize the interplay of obesity and sex. And, this is particularly a risk factor in the United States, where 40% of the population is obese. The prevalence of obesity is only 6% in China and only 20% in Italy. And so there have been substantial reports about obesity and its strong association with adverse outcomes and ICU admissions. And perhaps that obesity may tilt, unfavorable outcomes towards a younger population. And this was data that came out earlier in Annals that looked at about 7,000 patients from a Kaiser Permanente database. And here you can see that if you look at the sex stratified and age stratified data, it's clear that if you're younger than 60 years of age and happen to be obese, you have worse outcomes, as well as if you're male and happen to be obese, you have worse outcomes as compared to females. So I think that's important to know. Smoking is associated with worse outcomes as well. Smokers are 1.4 times more likely to have severe symptoms and about 2.4 times more likely to be admitted to the hospital and ICU requiring mechanical ventilation. So these are all cardiovascular risk factors. And so why may that be? And it's important to recognize that the prevalence of cardiovascular disease may be a surrogate for other comorbidities, and there may be functional immunosuppression, immune dysregulation, endothelial dysfunction, microvascular dysfunction, and this ACE2 activity that may play a role. And so there are certain sex differences in immune response, and we should know that. One is the virus entry, and we talked a little bit about the ACE2 level and the serine protease that helps attach SARS, the coronavirus, to the cell, but also differences in innate immune response as well as adaptive immune responses as well that may play a role in how well women do compared to men. And the ACE2 activity is something that is being actively studied, and we can talk about it more in the Q&A sections as well. But lastly, what is the status of the cardiovascular health in men? And this is data from the 2018 National Health Interview Survey that looked at the underlying risk factors. And, men are not very good at prevention and preventive care and don't regularly exercise. 36% are obese and 33% have hypertension. Just overall cardiovascular care in this population requires much improvement. But also preventive care. Men are less likely to see a doctor or less likely to make their preventive care visits. And I think that's really important. And perhaps a take-home point from this for us to educate our men patients. And lastly, implications for cardiovascular care. I think this is a time where we really have to re-energize prevention services and expand that with health education, community engagement, and public health outreach, but also consistently explore COVID-19 and its outcomes through sex disaggregate data. Perhaps also focus on health policy changes such as rehabilitation of these patients who have this, and so that they can return back to their normal lives. And with that, I'm going to finish, and we'll be happy to take questions. Thank you.
Thank you very much to all the speakers. We've got 5 minutes for question and answer. I was perusing the chat box, and I think all of these women-specific risk factors such as preeclampsia, gestational hypertension, diabetes, autoimmune disease that Dr. Gulati and Dr. Scott mentioned. I think that in the chat box, there's some discussion about like, what do we do once we identify these risk enhancers other than just putting these women in the intermediate risk group according to the Prevention of Women guidelines? Do we have anything else more that we can offer these women rather than just the traditional ACVD risk scoring and then looking at these risk factors specific for them and sticking them in that group?
I'll start. I'll say that the one thing is that certainly this is the group that someone brought up in the previous session, that when you assess ASCVD risk, especially if it's at the time of pregnancy, for example, these are young women, they're all going to have a low risk score. So they're going to look low risk. And they might have a higher lifetime risk. So it's really that's part of the issue when we use that. And that's where the risk enhancers help us change their stratification and prevention patterns for those specific women. But it also, depending on their age, you might decide to do some other type of imaging that would help you further risk stratify them. So especially if they're over the age of 40, you might consider doing a coronary calcium score on them to help, again, in terms of creating a preventive strategy. I think it depends when you see them. So for the autoimmune disease patients, you might see them at an age where they're a little bit older and they might actually have coronary calcium. I think when you see young women postpartum, for example, as many of our clinics do see those women, they're young, and you're not even going to probably do a coronary calcium score on them because the yield would be very low. So I think it's starting the prevention, though, very early would be, looking at all the risk factors and putting it all together, at least would be one form of strategy, identifying what the risks are right there and incorporating lifestyle. And I'm sure Dr. Scott has many other great suggestions.
I wish I did, Martha. It really feels not very good when a woman's holding her newborn, you tell her she's at risk of heart attack, but I don't really know how to reduce that other than tell you to exercise and eat better. I wish we had more, but I will say on the positive note, 10 years ago or 20 years ago when I was in training, we didn't even consider these as risk factors. So we've made a lot of progress. And I was just on service. I reiterated my fellow was taking pregnancy history on every patient by the end of the week. So we're doing, I think, a great job. And moving forward, I think we'll have more information. I think it's key to obviously inform the primary care team that these women are at elevated risk, and of course the patient. But I think we'll know more as time goes on because we have made a lot of headway.
If I may add, I think the EHR should prompt us while we're putting in the record or the chart. Did you take a pregnancy history? So I actually go back and actually do it. Hopefully they'll be iterated like that. But great points.
Well, and that's an interesting point because we really are lacking. Like if you look at the OB history, they may have all that information in there, but it's not in a place that a primary care physician would see it, or even a cardiologist. So if they get referred to me, then I get to see them and put that in. Otherwise, it's completely missing from their electronic health record based on the way, even when the birth happened in your same system, it's not necessarily there in a usable way. So I think that making that part of their problem list or whatever you want to call it, it's at least our job to start that conversation, and by us putting it in there, then it's there forever.
Excellent points. There was a question about follow-up for women who had gestational hypertension, preeclampsia, or diabetes. And I'm thinking that these women already are in the healthcare system because they're being followed by their OBGYN, unlike the slide that we saw of men, how they are getting into the healthcare system really quite late. And we have opportunities there. I think that, that they're being followed up by multiple people, but if you would like to comment on that, Dr. Scott, that would be great too.
Yeah, sure. I think again, there's no clear guidelines on how to do this. I think experts would say if you did have a pregnancy complication, it would be fair to see someone with interest in this. It doesn't have to be a cardiologist at least once to then review the risk factors with the patient and then communicate to the primary care team. I think the issue is probably our highest risk folks are people that lose their insurance, once they're off Medicaid, and 60 days postpartum, they're taking care of their family. They may have economic challenges, and taking care of themselves is probably the least thing on their list of things to do. So I think and I think this is also why maternal mortality in this country is such an issue. And so I think tackling this at a national level is important as well.
And I think that we really need to redefine the fourth trimester, if you will, because the way that everything's packaged right now is it's packaged for that delivery. And that postpartum visit was completely random to say that you needed a 6-week postpartum visit. And we know so many people don't do it, but like you said, there's cost issues about why people couldn't do more than that. Maybe their coverage is complete for their delivery, but after that, they'll have a copay or they'll have something if they get sent to a specialist. And I think the other issue is that they think of their obstetrician as their primary care physician. And some obstetricians are fantastic, obviously, at identifying these issues, but not necessarily treating them for the long term. They can treat them and they see their job, and I think rightfully so, as treating them through the pregnancy. But after that, they do need additional assistance. And if it's not covered, if it's not part of the fourth trimester care, then we're doing something wrong. And I do also think that women tend to not make that their after visits after the delivery for many reasons. In the United States, they're not provided with guaranteed leave after they deliver. And so I think that makes it very hard for them to keep with multiple appointments or even understanding. I think targeting them when they're in the hospital, we put big information where they deliver, where they walk when they're in labor to understand why they're going to get a referral to cardiology. And that helps. But again, their focus is either on their baby or soon after their job as well.
And my last comment is we made great strides in decreasing deaths due to cardiovascular disease in women from 2000 to 2010. But 2010, yeah. But you showed from 2015 and on, we have an increased risk of cardiovascular disease in women. Do you think that's because the Go Red for Women campaign is really kind of phased off a little bit? Do we need to increase our awareness campaigns again for both women, for both patients and physicians?
Well, you probably saw, like me, that paper that came out just last week by Dr. Cushman and all. And I think that really showed us that we are not increasing awareness. If anything, we've lost ground. We are not doing good. Even at people who have risk factors seem to be less likely to be aware of cardiovascular disease as their cause of death. So I think there's the Go Red for Women is important, but we got to keep at it. I also think we need to reconsider maybe our symbol of the red dress. Maybe that's not, people aren't getting clued into that. I get a question every day when I wear my red dress about what does that button stand for. And, the pink ribbon has made, everyone knows what that means. Everyone, male, female, they understand the link to breast cancer. We really need to get our preventive message out. We need to work with marketing people to understand the best way to get this conversation stronger. And we need to be bringing at the forefront of every visit, whether you're primary care, whether you're OB, whether you're a cardiologist, talking about, are you at risk as a woman for heart disease in the same way that we do for men? So I think we have a lot of work still to do. Risk factors are on the rise, which are contributing to that increase now that we're seeing in cardiovascular disease in both men and women. So it's really important for us to start getting this message through.
Thank you very much. With that, I just want to thank all the speakers. Those were excellent points, excellent discussion, excellent talks. We're going to switch gears now and go on to the next session of the next group of talks in this CVD Prevention Symposium. And this is actually going to be focusing on lifestyle wars is the name of this. And I'm going to give it over to our moderator, Dr. Ahmed Solomon. Dr. Solomon leads our virtual medicine at our clinic. So he's the forefront of anything virtual. And he is also a prevention specialist in general cardiology. Dr. Solomon?
Thank you, Dr. Omar. Good morning. My name is Ahmed Solomon from Houston Methodist. I have the privilege to moderate this upcoming session of Lifestyle Wars, which, in my opinion, is one of the most important nationally less implemented preventive cardiovascular measures. Our first guest has a very long established history in this field. Those of us that read coronary CT scans know his name very well for the scoring system for coronary calcium. Dr. Agassiz, excuse me, frankly, doesn't really need any introduction. He's a long and still actively practicing preventive cardiologist with special interest in nutrition, insulin resistance, imaging, detection of disease in its preclinical stages. He'll be discussing a very hot topic of nutrition, not just in the cardiovascular prevention arena, but in the diet world, generally speaking. The question many have: are carbs and fats not really created equal? Dr. Agassiz, it's a pleasure.
It's a pleasure to be here with you at Methodist Hospital and with such an august group. I'm going to talk today about how all carbs and all fats are not created equal. And to best understand this, we're going to look at sugar and lipid metabolism in its basics, and then see how different sugars and fats affect the metabolism. We're going to first look at whole food carbohydrates like sweet potato and whole grain bread. And this is metabolized rapidly into glucose, and glucose goes to all the cells in our body and all the organs. And in the liver, some is metabolized right away in the mitochondria. Other is stored as glycogen, and it's stored in the liver and in the muscle. The rest is turned to fat, and the fat is either oxidized in the liver, and much of it is packaged into small LDL. The small LDL is rapidly metabolized and has a short plasma residence time where it doesn't have time to get oxidized. It creates a large LDL that takes cholesterol and triglycerides to the rest of the body, but not to the vessel wall. When we look at fructose-containing foods, whether cane sugar, high fructose corn syrup, or fruits, particularly tropical fruits, the fructose acts quite differently than the glucose. It's almost all sent to the liver, with essentially none going to other organs or cells. And in the liver, like glucose, it may be metabolized in the mitochondria, but it's not stored as glycogen. Instead, it's by de novo lipogenesis, it's turned into fat. And the fat has to be either it stays in the liver, contributing to our new epidemic of fatty liver starting in young people, or it's stuffed into VLDL particles that become quite large. And like a large suitcase that doesn't fit into an overhead bin, the large VLDL is slowly metabolized, and its metabolites hang around in the plasma for a long time, get oxidized, get glycolated. And unlike the large LDL that doesn't get into the vessel wall, the small LDL sticks to the endothelium and is atherogenic. Well, why are there successful high carb populations if carbs aren't good for us? Well, obviously all carbs are not made alike, depending on food processing and its effect on incretin hormones. So if we have a certain amount of glucose, intravenously there's a very modest rise in insulin. But if the same amount of glucose is taken orally, there's an enhanced rise in insulin, and that's called the incretin effect. So with real food, how does this affect us? Well, if you have processed instant oatmeal, even with the fiber there, but not surrounding the starch core, you induce K cells to produce GIP, which gives a very robust increase in insulin and a large incretin effect. When you have a true whole grain like steel-cut oatmeal, where the fiber is surrounding the starch core, the metabolism is slower, and you stimulate K cells to produce GLP-1 in the more distal intestine, and you get a much more modified increase in insulin and a less of an incretin effect. Now, when you do produce small LDLs with high levels of insulin, the small LDLs, if we look at tertiles of small LDLs, the relative risk of coronary disease goes up. The smaller the particles, the more they are, the greater your risk of a coronary event. If we look at large LDLs, and this has been done with many clinical trials now, it doesn't move the needle. Large LDL alone doesn't increase events except in unusual circumstances. And so why give statins to lower LDL, particularly large LDL? Well, Dr. Christy Ballantyne actually looked at this many years ago when he looked at simvastatin in the 4S trial. And what he found was when you had the lipid triad, high triglycerides, low HDL, meaning small LDL, the simvastatin worked. You had a very significant decrease in events. Whereas when you had isolated large LDL, the simvastatin did not work. No significant difference compared to placebo. Now, Dr. Ralph DeFranzo has taught us that insulin resistance is really a continuum. And where do we get sick? Is it when we still have normal glucose tolerance, impaired glucose tolerance, or frank diabetes? Well, it turns out that we start to get that fatty liver way back here with normal A1C, normal glucose tolerance. And we get increase in triglycerides, decrease in HDL, small particles, again, way back here with normal A1C, normal glucose tolerance in the natural continuum of insulin resistance. So how do we know where we are on the insulin resistance continuum? Well, we do it by looking at the Kraft test, which measures the insulin, not just the glucose response to a glucose load. It's like the glucose tolerance test, but it's an insulin tolerance test. And normally after 30 minutes, you get a moderate rise in insulin, and then by 2 hours, it's back to normal. In insulin resistance, you get, even when your A1C is normal, you're not yet pre-diabetic, you get an exaggerated rise in insulin, which is keeping the A1C normal, and the insulin does not return to normal at 2 hours. Once you're diabetic, you don't get a big rise in insulin. It's delayed, and it almost never comes back. It takes a long time to get back to normal. So let's look at the natural history of insulin resistance, beta cell function, and dyslipidemia and diabetes. So here's beta cell function, and here's where we get beta cell dysfunction. And when we look at serum insulin levels and fasting blood glucose, it's after beta cell dysfunction that the glucose starts to go up and the insulin starts to drop. But what about dyslipidemia? And that starts way back here, as we just showed you, when glucose tolerance is still normal. So during normal fasting plasma glucose and fairly normal beta cell function, you already have small LDL and what we're calling pre-diabetes, and you can already have coronary calcium back here. Well, what's the deal with saturated fat? When we increase saturated fat in the meal, we increase total LDL. We increase large LDL, but we don't increase small LDL. When we look at the same amount of saturated fat, or less saturated, or more saturated fat even, as we increase our percent of dietary carbohydrate, we end up with more small LDL and less large LDL. And that explains a lot of what we see clinically. So when we decrease saturated fat in our diet, we can decrease LDL, but not the atherogenesis of small LDL. We may increase it. So in the Women's Health Initiative, low fat versus placebo, no difference in coronary events or any other events, cancer or other chronic problems. And in fact, in the women who had coronary events, they actually did worse with the low-fat diet. Let's look quickly at omega-3 versus omega-6. Bill Harris has shown when you look at the omega-3 index, not just the dose of omega-6, as the index goes up, you get less chance of an acute coronary event. And we know when you take in more omega-6, more vegetable seed oils, you diminish your omega-3 index. There's an inverse relationship. You can have the positive effects of omega-3 when you're having a high omega-6 diet. So how does this all work in a real patient? This is a 37-year-old who already had coronary calcium, though he had a normal A1C. Here's his belly at the beginning. This is after a 30-pound weight loss in 8 months. He reduced his belly. His large LDL increased. His small LDL decreased. You can see it particularly here. His large HDL increased. And this was all as his A1C decreased from 4.9 to 4.6. And let's look at his Kraft test. In fact, the insulin peaked earlier and not as high as at baseline as his A1C went from 4.9 normal glucose tolerance to even better glucose tolerance at 4.6. So let's look at a summary of his lipids. His total cholesterol went up. His triglycerides came down. His HDL went up significantly. His LDL particle number actually came down. And again, this was on no statins, no medication at all. His medium LDL came down. His A1C came down. His ALT and fatty liver improved. But when we look at his LDL, his bad cholesterol went up, but his small LDL at the same time went down. So even with an increase in LDL, he's clearly less atherogenic. Thank you very much.
Thank you very much, Dr. Agustin. That was a very enlightening presentation and frankly, very much needed. We have quite a few questions that we'll do at the end of the session. Another significant factor that's really important to manage, and many don't do so or unable to do so, is stress. Our next guest will help us with understanding its true impact. She also does not really need an introduction. Dr. Chanayan is a cardiologist and professor of medicine at Beaumont Hospital in Royal Oak, Michigan. She serves on the Society of Cardiovascular CT Board of Directors and Executive Committee and the ACC Imaging Council. And she's also the author of The Heart of Wellness. Dr. Chanayan, that's a privilege.
Thank you so much for having me at this wonderful conference. I'm really honored to be here. And today I will be talking about stress reduction and whether this is a farce or a fact as far as cardiovascular disease and prevention is concerned. These are my disclosures. So I'm going to talk about a set of facts. The first one being psychosocial stress is a thing. What is stress? So unlike other cardiac risk factors, stress is quite non-uniform. And it is a consequence of various unpredictable and uncontrollable factors, such as interpersonal relationships, previous trauma, financial constraints, employment-related issues, neighborhood, community, and society-related issues, politics, and the policies that directly or indirectly affect our life, discrimination based on race, gender, and other perceived disparities, and of course, unexpected world events such as a pandemic. Fact number 2, stress is associated with cardiac disorders. So there are numerous studies that have demonstrated this relationship, but I just want to talk about 2 of these. The first one being the InterHeart study. That was a very large global standardized case control study across 52 countries that looked at the association between smoking, hypertension, diabetes, waist to hip ratio, diet, physical activity, alcohol, apolipoproteins, and psychosocial factors, and the association between all of these with acute myocardial infarction. And if you look at the graph on the left, you can see that these are the various associations. And here is the one with psychosocial factors, which is very high and higher than all the other risk factors that you can see here, which are traditional risk factors. And then there is the Whitehall 2 study, which consisted of an occupational cohort of men and women working in central government in London. And this was also a very large study. And importantly, the follow-up was very, very long, across 3 decades. And here, the objective was to identify the extent to which individual risk factors and groups of risk factors are able to explain the social gradient in cardiovascular disease events. And so they looked at all-cause mortality, cancer mortality, cardiovascular mortality, and other mortality. And importantly, what we see from this study is that the lowest socioeconomic position had 1.6 times, almost twice the risk of death from all causes, individually as well as collectively, compared to the higher socioeconomic classes. And last year, we see this study that looked at 509 individuals who were of the lower socioeconomic status, and they all underwent a whole body FDG PET. And what we see here is this interesting relationship. And you see here in this figure, these are difficult to modify factors, which are the socioeconomic factors such as lower income and higher crime, and how these are associated with cardiovascular events and the mediation between the two, which is increased amygdala activity, increased bone marrow activity, arterial inflammation, and all of this is associated with higher major adverse cardiac events. And then we know really a lot about mental illness and cardiovascular disease mortality. And you see in this table, whether you look at cross-sectional studies or longitudinal studies, you see the very high adjusted odds ratio between each of these disorders, such as schizophrenia and major depressive disorder, with cardiovascular disease mortality. So when we look at this, the whole unfolding of events, you have, of course, all of our life situations that result in stress, such as work, family, disparity, and all of these issues. And that leads to a biological response, which is a combination, a very complex interplay between autonomic dysfunction, neuroendocrine activation, coagulation activation, and immune activation. And this results in accelerated atherosclerosis, plaque disruption, myocardial ischemia, electrical instability, and all of the other factors in cardiovascular pathology leading to cardiovascular events and morbidity and mortality, such as acute coronary syndrome, MIs, acute cerebrovascular events, AFib, and ventricular tachycardia or fibrillation. Fact number 3, stress is associated with worse prognosis and adherence to preventive strategies. Very important to understand the role of counseling our patients to adhere to medications or lifestyle and their stress levels. So here we see, for instance, in this study, an inadequate response to treatment in coronary heart disease, especially in those with type D personality. Type D personality individuals are generally hold a negative outlook towards life. And in this study, we see that type D personality is associated with poorer quality of life, absence of therapeutic response, and increased medical costs at 5 years. And if we look at long-term mortality and outcomes, this is another paper that looked at 4,000 odd acute MI patients. And then you see that this was, again, in 25 centers across the US. And you see that moderate or high stress is actually associated with poorer health, perceived poorer health, recurrent angina, as well as mortality over a long term, over 5 years. Fact number 4, just as stress was a thing, resilience is a thing. What is resilience? So if we define stress as a perceived threat to our well-being beyond our capacity to cope with it, resilience is the ability to withdraw or recover quickly from it. And this is a very fascinating area of science. And, you know, this looks into this aspect of neuroplasticity, which is the adaptation of the brain to changing stimuli by altered functional as well as structural properties. And what we know from neuroplasticity studies is that maladaptive behaviors are learned, and therefore they can be unlearned, and the brain changes accordingly. So what is resilience and what happens with it? So with resilience, there is a greater acceptance of our life situations, greater adaptation to uncertainty or change, such as the virus. We either adapt and evolve or we fall apart. There's greater self-care and increased motivation to make lifestyle changes, which is really a very large part of prevention, both primary and secondary in cardiovascular disease. Fact number 5, resilience appears to influence cardiovascular disease outcomes. So in this Spanish study, what they did is they looked at a group of patients that had acute coronary syndrome and looked to see if there was any association between resilience and objective markers of the extent of the ACS with biomarkers such as troponin and myoglobin. And so what they found is that self-efficacy, which is one of the components of resilience, is negatively associated with these biomarkers, which means people with resilience tend to have smaller infarcts and in an acute coronary syndrome. And this appears to be actually mediated by the white blood cells, and therefore this decreased association with inflammation and so on. And importantly, this is one study that looked at this issue of neuroplasticity, although this is an indirect measure of neuroplasticity, which is in about 200 African-American subjects who had had a myocardial infarction. This randomized study looked to see if there could be a decrease in secondary outcomes, in the secondary outcome or in the primary endpoint of cardiovascular mortality, myocardial infarction, and stroke. And they found that over 5.5 years, those individuals who were taught to meditate with transcendental meditation actually did way better. And there was a whopping 48% reduction in the primary endpoint compared to those that had standard treatment, but were not taught to increase resilience through this particular technique. Fact number 6 is that there are no large or long-term studies that look at the association between resilience and cardiovascular disease outcomes. There is also the problem of the lack of uniformity. There are too many methods to improve resilience, and there is a lot of bias in many studies based on the investigator's choice of method. So if you are a meditator, you will probably look at meditation and so on. And there is a lack of uniformly acceptable measures of resilience. How do you measure resilience? Because you may be the kind of person who doesn't fall apart even with a pandemic or a very great stressor such as a terrorist attack. And there may be somebody else who falls apart just by being stuck in traffic. So this thing is actually very difficult to measure objectively. Fact number 7, solutions to this problem of stress lie at both the global and the individual levels. As far as global levels go, we have to recognize that the problem exists. We must devise policies to address pervasive stressors that affect all of us, such as affordable higher education, basic necessities, work hours, and food industry, and so on. In my opinion, we must also reconfigure the meaning of success, and we must quit worshiping insane competitiveness and possessions as if that is the most important thing in life. At the individual level, we again must recognize that the problem exists. If we think that stress lies in somebody's head and has no effect on the heart, then that would be our first mistake. We must refer early and proactively to specialists. But in my opinion, also counseling patients about stress at every visit works and works really well. Asking, caring, encouraging, and really encouraging people to be pragmatic and not sentimental really helps. In summary, stress is associated with cardiac disorders, worse prognosis, as well as adherence to preventive measures. Resilience appears to influence cardiovascular disease outcomes. There are no large or long-term studies to demonstrate the effect of resilience on cardiovascular disease, and we need these kinds of studies. And solutions lie at both large-scale and individual levels. Thank you so much for your attention.
Thank you very much, Dr. Chinayan. That was very informative. We've got quite a few questions, and we don't have much time, so I'm going to kind of go through them quickly. So, Dr. Chinayan, one of the important questions that came up was any clinical tools that you could implement in your practice, your day-to-day practice, to assess stress levels and resilience, and have that discussion with patients with some objective data.
Thank you so much for having me here. This has been such a wonderful conference. And there are several validated questionnaires that could be used in clinical practice. And the Cohen's perceived stress score is one that is used most widely. It's the most well-known. And there are certain resilience questionnaires as well. But, these are great actually for studies and such. But in my practice, I think just talking to people gives you a pretty good idea of how stressed they are and what their resilience level is. If you have patients that come in and their blood pressure is high just because they walked, from a crowded parking lot into your office, that tells you that, they could probably use a little more resilience.
Dr. Agustin, quite a few questions, obviously, with your talk, more specifically regarding ketogenic diets, generally speaking. So a lot of the questions revolve around the saturated fats, the LDL that we measure in clinic on a regular basis, being the standard LDL panel. Usually, in that case, would be an elevated LDL on patients that are on a ketogenic diet. And how can we deal with that in our clinics on a day-to-day basis? And I think you're on mute.
Saturated fat.
He's enjoying the stressful time on the beach of the South Beach.
I thought we put South Beach in the background. The fact is, saturated total cholesterol is a surrogate for LDL cholesterol, which is a surrogate for LDL number, which is it's a surrogate for small LDL. Large LDL is not atherogenic by so many studies. And the study from Christy Ballantyne I thought was fascinating. I hadn't seen that before, going back to 4S, where the best surrogate really in standard lipid testing is triglycerides over HDL.
Yeah.
And in 4S, he showed treating that didn't work. Only treating the ones with essentially small LDL. And that's been shown in so many other studies. Ron Krauss recently in JACC has a fabulous review of saturated fat. And the Women's Health Initiative, with 50,000 patients testing low versus high fat, a few more patients than in the original Ornish study, which wasn't just a diet study, it was smoking cessation, exercise, and meditation, which we see works, may improve endothelial function, but does not cause regression of plaque.
And a question actually would kind of fit both Dr. Shanahan and Dr. Atkinson is the insulin resistance and the role of exercise and type of exercise with insulin resistance, in addition to stress, and how, and if there's any association between insulin resistance and exercise capacity and stress. Dr. Shanahan.
Well, as far as in insulin resistance, there's one Dr. Georgia Ede who's become a nutritional psychiatrist, and we do believe that high insulin resistance is associated with anxiety and depression. And as far as exercise, resistance exercise and lean body mass appears to be better than just aerobic exercise in improving in insulin resistance. And this is a new area for research.
Yes, I agree. I think this is actually a difficult thing to tease out because, with regard to insulin resistance and, metabolic syndrome, and in women particularly things like PCOS, there is so much of a psychosocial aspect that is involved in this a lot of times that it's difficult to tease out, whether it's a chicken and egg kind of thing. It's not, we are not clear if it is the stress is caused by, all of the metabolic things that are going on, or that's leading to stress, or it's mutual. But we do know that exercise actually increases endorphins and is really important for this resilience issue and for gaining a different kind of a perspective, I suppose. And that kind of also helps with the insulin resistance. But this thing that there is this insulin resistance, I think this is one thing that I stress with our fellows and trainees quite a bit, is that none of the hormones work in isolation. Everything works in kind of a en masse, and everything influences everything else. And so as long as we kind of understand that these neurohormonal pathways are quite complex and affect everything, we can safely say that a holistic approach that involves a sensible diet, exercise, and a perspective shift, all of these things make a huge difference in this whole process of prevention.
It may make one other point, please. Yeah, talking about your pregnancy, women's health, women routinely get a oral glucose tolerance test when they're pregnant. They should get the Kraft test, because at the young age, they will often have normal glucose tolerance tests, but if you measure their post-glucose load insulin, it's off the wall. And those are the ones who are going to have diabetes in later life and can be monitored.
Well, that brings up another question about changing the norm of what we check. As you're describing in patients that are working on a low carbohydrate diet or a ketogenic diet, and many questions come up that LDL levels skyrocket on a patient that already has established coronary disease, and that makes a lot of people very uncomfortable. Should we change our lab order sets?
Yeah, we should be looking at small LDL. And in the patient I showed, 30-pound weight loss, lost his belly, and his total cholesterol and total LDL cholesterol went up, where all his other, his ALT, even his liver function, he clearly improved his risk. Now, there are times when high LDL large LDL is a problem. In FH, if you have fewer receptors that you're clearing, and with large LDL, with large HDL, you can be at risk if you have longer time in the plasma, longer residence time, and that's what makes lipids atherogenic, not the total amount per se.
Well, to be honest with you, I think with this lifestyle session, we could keep on going for another hour, because I think it's really, really important, things that we don't really have a lot of tools to work on, or we don't actually work on as much as we should be. But we're tight on time, and we're going to, and I would like to thank both of you very, very much. It's been a pleasure. It's been an honor. Thank you.
Thank you.
Our next session will be moderated by Dr. Peter Jones from our Center for Cardiovascular Disease Prevention at the Houston Methodist Debakey Heart and Vascular Center and Baylor College of Medicine. And that will revolve around evolving therapies in cardiometabolic management. Dr. Jones.
Thank you very much. I really appreciate the opportunity to be here today and to moderate this wonderful session called Evolving Therapies in Cardiometabolic Management. We've got three presentations. I know we're running a little bit behind, but I hope we'll be able to sort of catch up and go through things. So our first presentation is by our host today, Dr. Nasir. And I don't need to introduce him. I think he's already been introduced at the very beginning. So his presentation is on PCSK9 inhibition. The future is bright.
Good morning, everyone. Delighted to speak about the future of PCSK9 inhibitors. Now, PCSK9 inhibitors' scientific translational from bench to bedside over the past decade has rightly been highlighted as the top success stories in cardiovascular disease management that eventually would, in my view, lead to a Nobel Prize to the investigators Helen Hopes and Jay Cohen at UT Southwestern, who made the discovery that individuals with the loss of the functional mutation in PCSK9 that results in the LDL receptor degradation has been observed to have a low lifetime levels of LDL cholesterol and lower prevalence of cardiovascular disease that resulted in a feared race among the pharmaceutical industries, mainly focusing on blocking the protein via targeted monoclonal antibodies that needed to be injected once or twice a month, that finally showed that significant reduction in LDL cholesterol up to 60% as compared to 20 to 45% seen historically with statins. Now that furthermore, the cardiovascular community was rightly ecstatic as this new therapeutic class undeniably resulted in improved outcomes in two landmark studies, which is the Fourier and the Odyssey trial. However, these celebrations were short-lived. Adoption of PCSK9 inhibitor in the first half from day one of approval faced an uphill battle worldwide. For example, leveraging large national insurance data sets, studies reminded us that approximately half of those prescribed actually got pre-approved. And even if they got approved, Dr. Marie Navarre clearly showed us that many of these individuals eventually had to discontinue because of the higher out-of-pocket cost. Now, for both patients and physicians, these barriers are extremely disheartening. And while there are many reasons for this, PCSK9 inhibitor price worth was a core and a contentious issue. And someone even as more important, considering for all new options, the fact that even today, without these expensive medications, nearly 1 in 8 patients nationwide are already skipping medications, cutting the pills in half, and even delaying the prescriptions solely due to cost. In fact, the summer of 2018 was pretty hard for PCSK9 inhibitors. 3 back-to-back investigators published and determined that with the initial price of $14,000 a year, PCSK9 will not be cost-effective from the broader societal and private insurance perspective. Now, as we were getting acquainted to these challenges, 2 main solutions were proposed. First, the editorial board at JAMA Cardiology, without mincing words, made it very clear the only path moving forward is cutting back the cost. Second, some of us proposed a middle ground that even among ACVD, there is a potential value proposition if you focus among those who are at the highest risk, will allow us to derive the most absolute benefit, and fewer individuals would need to be treated. As a result, we can derive a higher yield for every dollar spent. Now, cognizant of these issues, the cholesterol management guidelines in 2018 and 19 for the first time also took into account the value proposition, trying to hold a middle ground, and recommended that PCSK9 should be limited to those individuals who are very high ACVD risk group, that includes those with multiple major ACVD events, or at least one event with multiple risk factors. Now, post-guidelines, we witnessed at least 3 major positive developments. First, I think as a direct result of the value-driven recommendations by the guidelines, we immediately witnessed a significant reduction in the prices up to 60% that were initially proposed and vigorously defended. Second, further evidence started percolating that focusing on the very high risk group, as recommended by the guidelines, had merit, and because the benefit with the PCSK9 monoclonal antibodies was much prominent. And if we focus on the very high risk group with the new pricing, utilization of the PCSK9 inhibitor becomes extremely cost effective from the population health management perspective. Now, how different that is just a couple of years back. Thirdly, the most exciting part was also introduction of a new kid on the block, inclisiran, which rather than blocking the PCSK9 protein is a small interfering RNA molecule targeting the hepatic production of PCSK9 with a similar reduction in LDL lowering that was seen in 3 phase 3 studies. Now, although we are awaiting the FDA approval towards the end of the year, I think so we are balancing our excitement by these additional options. I think there's going to be a potential competitive pricing more, and with this unique twice yearly subcutaneous regimen, but also we remain on guard whether we can witness similar challenges in adoption as seen with the PCSK9 MABs, and we are still a few years away from outcome studies. And in some circles, the long-term safety still remains a concern, although in the early 3 to 4 years, we have seen pretty good signals. Now, if we start reimagining the future, and in doing so, the first challenge, but also the opportunity for us, is to overcome the therapeutic inertia that is providing the right treatment to the right patient at the right time. While according to many estimates, conservatively 10% of ACVD patients are candidates for PCSK9 inhibitors, the uptake nationwide is dismissal and up to only 1%. Now, this calls for a pause in the current strategy. And I think so we need to acknowledge the challenges of prescribing PCSK9 may not be the same as prescribing a statin, and we need to have a systematic approach. We have to think locally, and we have to build resources, leveraging big data and creating digital solutions like dashboards and alert system. We have to invest in specialized service line like preventive cardiology divisions, leading these efforts with automatic referral to these groups. Tailored education is going to help, and I think we need to incorporate these as key performance matrices. Almost exclusively used in outpatient setting, we can also reimagine in the future that the PCSK9 inhibitors will be initiated in the hospital for the higher risk groups coming with ACS. For example, in this interesting study among 300 ACS patients, the European study showed that initiating PCSK9 on top of statin post-ACS in 8 weeks was extremely feasible and actually led to a significant improvement in getting to LDL goals in almost 100% as compared to 40% with standard of care. However, I think that there is definitely merit in this strategy, and we'll be best served if we focus those on already on moderate to high dose statin with elevated LDL, or a combination, even if the LDL is greater than 70, and someone with severe hyperlipidemia. We are clearly seeing the expansion of the use beyond those with established cardiovascular disease. There are ongoing clinical trials such as the Vascular trial assessing outcomes in varying range of those at high risk without established ACVD. There is definitely a growing consensus that among traditionally high-risk individuals such as diabetes, that there is a significant value of double enrichment, and we may be better served if we focus on markers of atherosclerosis such as calcium score greater than 100 or 400 rather than guesstimating on biomarkers. Now, clinical adoption, and if we limit that to the extensive atherosclerotic burden, in my view, it's going to be reasonable. Now, fourthly, the thing that excites me the most about the future is the possibility of considering a vaccine-driven population-level LDL lowering approach. Now, with the arrival of possibilities of having just 1 to 2 shots of inclisiran in a year that provides similar LDL reduction as with 365 pills of statin, I think we can dare to be brave and think about extending way beyond into populations such as those young, high-risk young individuals without ACVD. And that may open doors of potential gains such as population-level LDL optimization, plaque regression, and we can for the first time think about plaque prevention. I strongly encourage that we engage in these discussions sooner than later, while also at the same time being cognizant of the societal implications from safety, cost, and implementation standpoint. So in summary, today, and as the 2020 is ending, I'm even more optimistic about PCSK9 inhibitors, and I think the future is bright for the following reasons. Number one, it's well established and proven in outcomes. Now we have extended support from the guidelines by both the ACC, AHA, and the European Society. I think so we are seeing the highest dividends for those at the highest risk. And I think so the same mantra can extend to those in the prevention levels. Now, as I said in 2019, if we focused on value and cut back the price and emphasize among the right patients, pricing will no longer be the top story in 2020. And that's true. And now we are seeing that actually utilization of the PCSK9 inhibitor is extremely cost effective. I'm very excited about the opportunities for early initiation during hospitalization, as so far PCSK9 inhibitors have been limited mostly to the outpatient settings. In 2 to 3 years, I am confident that we'll have an expansion into high-risk patients who are free of clinical ACVD, and a group that is most likely going to benefit are those with the highest coronary artery calcium scores. And now with the siRNA therapies on the horizon, we are going to have much more options, more dosing options, and potentially likely competitive prices. But the thing again that excites me the most is about the opportunity of having a population level health approach for LDL lowering vaccination concept is truly on the horizon. And the way preventive cardiology will operate in the next 5 to 10 years, it will be very different than what it is today. Thank you so much for the opportunity.
That was a wonderful presentation. I hope that we'll be able to have time to answer some questions. Some of them are already in the chat room, and so keep watching those for some of the answers that are coming up, and we'll see if we can answer some of them briefly at the end of our presentations. So let's move on to our next discussion by Dr. Ron Blankstein, who's co-director of the Cardiovascular Imaging Training Program and director of cardiac computed tomography at the Brigham and Women's Hospital, where he's also an associate professor in medicine and radiology at Harvard Medical School. He's going to talk to us about a very important risk-enhancing lipid factor, and the title of his presentation is New Kid on the Block, Would Measuring and Lowering Lp(a) Matter? Ron?
Hi, my name is Ron Blankstein. It's a great honor to be part of this meeting and to speak with you today about lipoprotein A. I'm going to start with the story of Bob Harper. At the age of 52, Bob was exercising in his gym in New York City when he experienced sudden cardiac death. Fortunately, he was resuscitated by a physician who happened to be in the area. But when this story broke, many individuals asked, how could this have happened to him? After all, for those of you who do not know who Bob Harper is, he was a famous celebrity personal trainer who became famous on the show The Biggest Loser. Well, how did this happen to Bob? Several weeks after his myocardial infarction, he saw a preventive cardiologist and was found to have an elevated level of lipoprotein A heart risk factor even doctors know little about, at least according to this article. Lipoprotein A was first discovered in 1963. This slide shows the structure of lipoprotein A. It's made of an apolipoprotein B component, which is linked covalently to apolipoprotein A. The apolipoprotein B, which is in the center here, has LDL cholesterol, also has oxidized phospholipids, which are thought to be associated with increased inflammation. The apolipoprotein A has a structure which is shown on the bottom here. This is a structure that is similar to plasminogen. However, apolipoprotein A has 10 different Kringle 4 units, but the most interesting part is the Kringle 4 subunits 2, and the number of copies of this Kringle or the number of repeats determines the serum levels, such that when there's a lot of Kringle 4 subunit 2 repeats, the serum levels are low and the risk level is low. But then when there's few of these repeats, the liver makes more of this compound, and as a result, the risk to patients is high. So lipoprotein A is truly a triple threat. It causes both increased inflammation because of the oxidized phospholipid, increased thrombosis because of the similarity to plasminogen, and effectively decrease fibrinolysis, and also increase atherogenesis because of the LDL, and possibly because of the hydrophilic nature of this molecule, which promotes entry into cells. So what is the distribution of lipoprotein A in the population? According to the Copenhagen General Population Study, the 80th percentile is at 50 milligram per deciliter, both for men and women. So this is often used as a cut point. However, the higher the threshold that we would set, the higher the event rate for our patients. Well, what determines these levels? This is determined based on the LPA gene, and we all have 2 copies, one from each parent. However, there's certainly much variability based on various SNPs that have been identified to date. The levels, however, because they are genetically determined, are stable over time and do not get impacted by diet or other environmental factors. So lipoprotein A is thought to cause a higher risk of myocardial infarction and stroke, but also now is associated with calcific aortic stenosis, with an increased risk of PAD, DVT, and PE. So given all that, should we measure it? Well, according to the 2019 ESC guidelines, all individuals should have this measured at least once in their adult lifetime. In the US, our recommendations are not quite as strong yet. This is just classified as a risk-enhancing feature. And in fact, if it is measured, it's considered elevated if the lipoprotein A levels are greater than 50 milligram per deciliter or 125 nanomoles per liter. And if it is in fact elevated in individuals that have a 5 to 20% risk, this can count as a feature that would favor statin initiation. So how do we treat patients with elevated lipoprotein A? I'm sure many of you have some of these patients in your clinic. And given the increased risk of cardiovascular events, I think the first thing that we all do is try to achieve lower LDL cholesterol. But this is not always easy, because when we start treatment with statins, for example, the LDL that's actually in the lipoprotein A structure does not get affected. And as a result, we sometimes have to calculate what's called the corrected LDL. And this is the LDL that we measure or calculate minus 0.3 times the lipoprotein A concentration. So if we have a patient that the lab comes back and tells us the LDL is 90 milligrams per deciliter, but if we also know that their lipoprotein A is 120 milligram per deciliter, the corrected LDL is 54 milligram per deciliter. And in fact, this may be a patient who actually is responsive to their statin therapy, but we may not appreciate it. So when you treat a patient with a statin and you don't see a significant enough reduction, one clue is to always measure lipoprotein A. So aside from LDL lowering, we should also think about antiplatelet therapy for these patients because of the higher risk of thrombosis. And in fact, in some patients, particularly if they already had an event, antithrombotic therapy becomes very important. Obviously, this has never been studied in trials in this particular patient population. We also have to treat all other underlying risk factors, whether hypertension or diabetes or lifestyle factors. In fact, I shared with you the story of Bob Harper, and I do find it interesting that after his event, Bob switched from a ketogenic diet to a fully plant-based diet. The other treatment is LDL apheresis. This is, of course, rarely done, but some of the clue that there may be a signal of benefit with lowering lipoprotein A comes from studies looking at LDL apheresis. And in these non-randomized retrospective studies, there's a signal of benefit to patients who get LDL apheresis. What about PCSK9 inhibitors? Well, in the 48 study, evolocumab was associated with a 27% reduction in lipoprotein A. However, this study did not enroll patients that had elevated lipoprotein A, so the absolute reduction was quite small. It was 11 nanomoles per liter. However, this sub-study from Michelle O'Donoghue suggested that it is indeed the patients that had lipoprotein A, which was elevated, who experienced a higher benefit from PCSK9 inhibition. Specifically, what we can see in this slide, that patients that had a higher lipoprotein A, whether higher than the median or higher than a value of 120 nanomoles per liter, had a lower hazards ratio. And even though the p-value for this interaction was not significant, this suggested that they benefited more from PCSK9 inhibition. Well, one question that often comes up is how much do you actually have to lower lipoprotein A to really make a significant and clinically meaningful difference? This is a slide from a large Mendelian randomization study, which tried to answer the question of what reduction in lipoprotein A is necessary to achieve the same benefit that we have observed when reducing LDL cholesterol by 1 millimole per liter. So on the left side of this slide here, we can see that when we reduce LDL cholesterol by 1 millimole per liter, the event or the reduction in events that we typically observe is 20 to 25%. If we wanted to observe that same amount by reducing lipoprotein A, this study estimates that the reduction may need to be 100 milligram per deciliter. This is the absolute reduction. And certainly, this is just an estimate, but the point here is that we would have to have a very large and significant reduction in lipoprotein A to really see a large benefit in or reduction in clinical events. So do we have any compounds that can do this? And the answer is perhaps. We now have ongoing clinical studies, which I will share in the next few slides. So first, from Amgen, a compound which is called Amgen 890, and is a small interfering RNA. This is a compound that now is undergoing a phase 2 trial. The design is shown on this slide here, and this is a trial being run by the TIMI group at Brigham by Michelle O'Donoghue. The next compound that we can talk about is Novartis TQJ230, and this slide here shows the phase 2 results that were published in the New England Journal of Medicine. This compound is an ASO, antisense oligonucleotide, which decreases the liver production of lipoprotein A. This was first developed by Ionis, and then this became under Axia and now acquired by Novartis. And in this phase 2 trial, what was observed is that patients who were treated with the 60 milligram sub-Q dose once a month had a 72% reduction in lipoprotein A. So this is, of course, a significant reduction. Interestingly, CRP did not change significantly. So based on this phase 2 trial, Novartis has now launched a pivotal phase 3 study. There's now a name to this agent. It's called pelacarsen. And this slide shows the study design. It will enroll individuals who have a lipoprotein A that's greater than 70 milligram per deciliter. And the endpoint here is MACE, composed of cardiovascular death, non-fatal MI, non-fatal stroke, and urgent coronary revascularization requiring hospitalization. So stay tuned. The follow-up is 4 years, a little over 4 years, and hopefully a couple of years from now, when we have the results, we will finally have an agent that not only lowers lipoprotein A, but hopefully also reduces cardiovascular events for our patients. So in conclusion, the answer to the title that was posed to me is yes, measuring and lowering lipoprotein A will likely matter. And I say likely because we still don't know the results of the trial. But I will conclude by saying that lipoprotein A is a causal factor in the development of cardiovascular disease, but also associated with calcific AS, PAD, DVT, and PE. On a population-wide basis, it is elevated in 20%, but for many of us as preventive cardiologists, we see patients who already had risk or perhaps have a family history. I suspect this number will certainly be higher. It's associated with increased atherosclerosis, increased inflammation, and potentially increased thrombosis. And therefore, in 2020, the treatment currently revolves around treating all other risk factors for cardiovascular disease, including lowering LDL cholesterol and often antiplatelet therapy with aspirin. As I have shown you, there's ongoing trials. There is an ongoing phase 2 for the Amgen compound, which is a siRNA, and an ongoing now phase 3 for the Novartis compound, which is an ASO. Both of these are compounds that essentially decrease production of lipoprotein A by the liver, and hopefully these will elucidate some therapies in the future that will be helpful for all our patients. I look forward to taking more questions during the Q&A, and thank you very much.
Thank you very much, Ron. Please keep up in the chat room. We're going to try to answer most of the questions if we can. I encourage our speakers to engage in the chat room to answer questions, because we are going to be limited in the amount of time we'll have to go through these questions. So I'm now going to move to our last presentation in this session, which is by Dr. Michael Blaha, who is in the Center for Prevention of Cardiovascular Disease and a professor of medicine at Johns Hopkins School of Medicine in Baltimore. And his presentation is going to be on should GLP-1 receptor agonists and SGLT2 inhibitors be your first choice in managing cardiovascular risk among diabetics. Michael?
with the PCSK9 MABs. But if you look from an adherence perspective and considering from the health system's viewpoint, most of these CVD patients, if they're going to have at least 1 to 2 every 6 months a clinic visit, potentially that can be utilized. But irrespective, I don't see any major problem from an adherence standpoint. I think that it should be better than what you can have with the 12-month. The question really is going to be whether the pricing is going to be more effective, similar, or better, number one. Number two, many folks have raised issues with potentially long-term safety, which we still don't know. But as far as the first 3 to 4 year safety is concerned, from the phase 3 trials and other follow-up studies, it's been pretty reassuring. So I'm pretty excited about the new options. It's great for our armamentarium. I think so. It's the more options for the patients, the better.
That's fabulous. And Ron, following up on that, you mentioned that currently the only effective treatment that may be beneficial for lowering high Lp(a) is to use a PCSK9 inhibitor. So yes, you need to lower LDL more, be more intense with your lipid therapy, but is the high Lpa patient the one where you would move more quickly and more effectively to PCSK9 inhibition?
Yeah, I think the short answer is yes. If especially if they have another indication for PCSK9, they have both an elevated LDL cholesterol and elevated lipoprotein A. I think that would certainly be a patient that you would go for a PCSK9 inhibitor. I would say, though, that the reduction is relatively small. It's a 20% reduction. So I think the newer agents that I pointed to, we're thinking about 80% reduction. It's going to be a lot more impactful.
Yeah, those medications are going to take a while to get approved, and we still got to get some outcomes to determine whether selective lowering of Lp(a) in patients actually contributes, as we expect it should, to beneficial outcomes on top of optimal LDL lowering. I know you've been sending in some great questions in the chat, and I know our speakers have been doing a great job answering them. So keep them coming, and I know our speakers will continue to answer them. So I do want to thank Khurram, Ron, and Michael. Thank you so much for your contributions, and if you can, stay around and answer questions for us, because we need to move on and get to the next session, which is our last section. And I'm going to send it back to Khurram, who's going to help arrange and organize this last session, including a keynote speech. Thank you.
Peter, thank you so much. Yeah, it is my honor and really a pleasure introducing and Dr. Dan Rader, who's our keynote speaker, who will be talking about the past, present, and future of familial hypercholesterolemia management, and more importantly, why do you care? He doesn't need any more recognition. He's the Seymour Gray Professor of Medicine at Perman School of Medicine at UPenn. He also serves as the chair of Department of Genetics and chief of Division of Translational Medicine and Human Genetics. And his major focus is on the human genetics and functional genomics of lipoprotein metabolism. I can tell you this is not one lecture to miss. I'm very excited, looking forward to this lecture, and then following with that a three-way debate, and then a more detailed discussion between the panel members. So please hang on with us, and it's a very exciting final session of our first annual CVD Prevention Symposium.
Hello, I'm pleased to be with you today. My name is Dan Rader, and I'm pleased to be here to present to you on the past, present, and future of FH care in the US. I'd like to start with a true story of a woman with FH who had an LDL of greater than 350, found at age 15, was not treated, had a myocardial infarction at age 38, and finally at age 41 was diagnosed with heterozygous FH and placed on aggressive lipid management therapy, initially getting her LDL down to about 160, and currently, with modern therapies, is down to an LDL of about 60. Indeed, this is the story of Catherine Weilman, the founder and CEO of the FH Foundation, who was so inspired by the challenge of having been diagnosed and treated with FH, that she committed to starting the FH Foundation to make sure that the awareness of FH and the appropriate diagnosis and care of FH patients is improved in this country and around the world. Of course, as we all know, FH is an eminently treatable disease. Early and aggressive treatment of FH saves lives. This is a figure from a paper about 7 years ago now, clearly demonstrating that patients with FH who are started early on statin treatment do much, much better in terms of cumulative event-free survival. FH is a treatable disease, but we need to identify it, diagnose it, and treat patients with it early. Familial hypercholesterolemia is common. Current data suggests that as many as 1 in 250 people have FH. Untreated, FH is life-threatening with as much as a 20-fold higher risk of heart disease. As I've just mentioned, FH is manageable. We have good therapies for this, and we can lower LDL and cardiovascular risk to basal levels. And finally, FH is markedly underdiagnosed. Approximately 90% of patients in the US who have FH have not been formally diagnosed with FH. Therefore, all of these really come together to suggest that FH is low-hanging fruit for public health interventions. In fact, because it's on autosomal dominant, highly penetrant, and has an early detectable biomarker, LDL, that is an example of why public health interventions really may substantially reduce the burden of FH. Mike Brown and Joe Goldstein, who of course won the Nobel Prize for the discovery of the LDL receptor and the cause of FH, wrote back in 1996, Heart Attacks Gone with the Century, really reflecting the enthusiasm for the effect of statins on reducing LDL and cardiovascular risk. While this may have been a little bit optimistic, it certainly reflects the treatable nature of this disorder. The picture on the right, by the way, is a picture of Doctors Brown and Goldstein being awarded the FH Foundation Pioneer Award, an award that's given annually at the FH Summit to pioneers in the field of FH. 2 years later, September of 1998, the WHO put out a report on familial hypercholesterolemia, led by the late Roger Williams, as well as a group of experts from around the world, really prioritizing FH as a public health concern. Again, on the right is a picture of this group of individuals, minus Dr. Williams, who tragically died early in a plane crash. Really showing that the foundation gave this group of individuals essentially the Pioneer Award posthumously in honor of Dr. Williams to this entire group of individuals who had contributed to this report. The CDC in 2012 designated FH as a Tier 1 health condition for cascade screening, recognizing that because of its autosomal dominant condition, that it is a significant public health concern, that there are effective therapies available today, that in fact, FH is a really terrific example of precision public health, applying the tools of precision medicine to public health to identify and treat patients with FH. So the FH Foundation, founded by Catherine Weilman, really has the approach of collecting big data. I'll show you a few examples of that, to really make sense of the data, to combine that with medical expertise, physicians and genetic counselors and nurses who specialize in FH care, along with the patient experience, really hearing from patients themselves about what it's like to have FH, what the challenges are, and putting all this together as an approach to try to improve the identification and care of patients with FH. So back in 2012, there were a lot of barriers to care in FH. Lack of awareness, market underdiagnosis, no ICD-9 or 10 code, no routine use of genetic testing in the US, no systematic approach to cascade screening, no registry for FH in the US, no systematic attempt to find undiagnosed FH patients, underutilization of existing therapies like statins, and unmet LDL lowering needs. Many patients with FH, even with statins, were unable to achieve LDL goals. The FH Foundation launched the Cascade FH Registry, a registry that is intended to enroll patients with FH and follow them longitudinally. And you can see there are 33 leading institutions as part of the Cascade Registry. There have been over 6,000 FH patients enrolled to date, dozens of published manuscripts and presentations. 4,300 of these patients are longitudinally followed. And this has turned out to be a very strong advocacy tool for advocating for additional funding for the treatment and care of FH. So the registry has really resulted in multiple manuscripts related to the natural history of FH. This slide summarizes one of the conclusions, that among the folks in the registry, the average age of statin initiation in these patients with FH was 39 years old. The average age of the actual formal diagnosis of FH was 47 years old. I think this shows that diagnosis and treatment come too late in patients with FH. As I've suggested, in the US, FH is markedly underdiagnosed. In this article from 2013, showing the rate of diagnosis of FH in countries around the world, the Netherlands, I'll note, leading that. The US was way down at the bottom with, at that time, less than 1% of patients with FH having been formally diagnosed. Why is this important? Why make the specific diagnosis of FH? Well, it has implications for refining the assessment of lifetime risk of cardiovascular disease, guiding the intensity of LDL-lowering therapy, affecting access to specific therapies for LDL lowering, such as those that require the diagnosis of FH, and influencing the approach to family-based cascade screening. Telling someone they have FH makes it even more imperative that they encourage their family members to be screened. One of the issues I touched on was the lack of an ICD code for FH. The FH Foundation got squarely behind the concept of trying to promote a new ICD-10 code for FH. Shown on the left are pictures of 3 individuals associated with the foundation who testified in support of the creation of this code. And in fact, in 2016, an ICD-10 code for FH was approved. And you can see at the bottom the increase in the diagnosis or the utilization of this code, ICD-10 code, over time since the initiation of this code. One of the huge advantages of now having an ICD-10 code is that large big data analyses can be done of individuals who have been diagnosed using this code. Kelly Myers and his colleagues at the FH Foundation have really employed a big data approach to better understanding the treatment of FH. And this slide shows that, in fact, many individuals diagnosed with FH using this ICD-10 code are markedly undertreated. And I'll just focus on the column on the left, the bar on the left. These are individuals, as of December of 2018, who had been diagnosed with FH using the ICD-10 code. And you can see that 42% of these individuals at the bottom of that bar had no evidence in their clinical charts that they had received lipid-lowering therapy in the past 6 years. So I think this does indicate the marked undertreatment of patients, even those who have been formally diagnosed with FH. So we think a lot about how do we reduce the population burden of FH, and I'm sure you do as well. What can we do about this disorder that we understand well, that we know is treatable, but there's still so many patients who haven't been diagnosed and are being undertreated? So one of the challenges is finding the patients. How do we find more of these patients who we know are out there, but have really never been diagnosed with FH, and in many cases are not being appropriately treated? Again, Kelly Myers and his amazing colleagues at the foundation have put together this huge big data project that they call Find FH. And Find FH really utilizes extremely large-scale data from claims data, from laboratory data, from prescription data to really put together a picture of who may have FH. So Kelly and his colleagues used known FH patients to train this model, this machine learning model, and then applied that model, that algorithm, to these large amounts of data. You can see 220 million people are included in this. to try to identify those who actually have FH. And on the right is a heat map of FH based on identification using this model. This has really been quite an amazing journey to be part of a collaboration with the foundation at Penn in terms of testing this model. So we've worked with the foundation to apply this model to the large EHR at Penn. The other institutions have also worked with the foundation. A paper was published in Lancet Digital Health about a year and a half ago with the title shown there, Precision Screening for FH, a machine learning study applied to electronic health encounter data. And what this study basically found is that instead of going through 1,760 people in the general population to find 8 FH patients, this algorithm allows flagging of suspected FH patients such that of every 10 that are flagged, 8, based on rigorous chart review and clinician expertise, actually have FH. So this is a model that really allows us to sift through big data, come down to a much smaller number of individuals who are highly likely to have FH, and then nominate them for more rigorous screening to see if, in fact, they do have FH. A very exciting application of machine learning to really identifying FH patients. So now that we know that this algorithm works, the challenge now is to implement it in large health systems to find those patients in these health systems who have FH. As I said, we've worked with the foundation, Oregon Health Science University, OHSU, and there's several other institutions that have worked with this group as well. Methodist Hospital may be one that would be interested in doing so as well. And you can see that the idea here is to use health encounter data, flag patients with FH, of course, do this all under application of HIPAA rules. Patient identification is maintained by the health system itself, and then apply the algorithm and actually flag those patients who are most likely to have FH, and then return that information specifically to their clinicians, who can then act on that by trying to make the diagnosis of FH if appropriate, and intensifying therapy in those who need more intensive therapy. So that's one approach, finding the patients. But of course, another key issue is once we identify patients with FH, and the reason that the CDC identified FH as a tier 1 condition for precision population health is that, in fact, cascade screening off these individual patients can be done. So once we've identified a patient with FH, they really need to carefully talk with their immediate and extended family to really point out that, in fact, because they have this genetic condition, there's a high likelihood that other members in the family do as well. So cascade screening, going from the proband and cascading out to other members of the family, is something that's been done very successfully in certain parts of the world, such as the Netherlands, but really is not done very effectively here in the US. Josh Knowles, Muin Curry from the CDC, and I published in JAMA a couple years ago a sort of an overview or a review of cascade screening for FH. This is a figure from that paper. We pointed out that this is a very messy process. In this particular figure, the proband shown on the left with an arrow is from Oregon, but you can see that there's certain family members that live in Virginia, others that live in Texas, and not shown on this slide, but in fact, what we know from our research is that, in fact, many of these families are not necessarily in all that close touch with each other. So trying to cascade from a new FH proband to other members of the family is, in fact, very challenging to do and is poorly done in the US. I don't have time to go into the details, but we're very interested in genetic testing for FH. What might the role of genetic testing be? And one of the questions we posed is, might genetic testing actually enhance family-based cascade screening for FH? And the study was set up as a randomized study, essentially testing this hypothesis. Currently, standard of care is you find a patient with FH, you basically tell that patient, maybe, hopefully, that they have FH, or at least that they have high cholesterol that might be genetic, and that it's important to get your relatives checked. This is the current approach. We hypothesized that an alternative approach might be to do genetic testing, find a gene mutation, tell the proband that they have a mutation that's causing high cholesterol, and that it's important that the relatives get checked for this mutation. We reasoned that, in fact, telling a proband that they have a specific gene mutation might enhance the enthusiasm of the proband and the family members to get screened for that mutation. I don't have time to show you the results, but our results from the study are that, in fact, identification of a gene mutation did significantly enhance cascade screening for FH. But I also have to tell you that despite trying very hard, our overall rates of cascade screening were very low. This is a very challenging process and one that we need more research to really figure out how to do more effectively. So I mentioned genetic testing for FH. One of the things that the FH Foundation did a couple years ago is convene an international panel of experts in FH around the question, should we be doing more systematic genetic testing in the clinical setting for FH? And this is the publication of that report in JACC. And basically, our conclusion was, after lots of discussion, is that in the current modern era, patients who are suspected or diagnosed with FH should be offered genetic testing. Not necessarily required, but offered genetic testing with an explanation of what the pros and cons are, and allow the patient to choose whether or not they'd like to do that. Our rationale for genetic testing in FH was several. It provides a definitive molecular diagnosis of FH. It provides prognostic and risk stratification information. It facilitates family-based cascade screening. It allows for precision during genetic counseling. It has value to the pediatric patient population with FH. It has personal utility to that individual, and data suggests that it has minimal adverse psychological impact. So in fact, we felt that based on all of these factors, offering patients diagnosed with FH the opportunity to undergo genetic testing is something that in the US, in the modern era, should be done. Finally, once we've found patients, we've tried to cascade screen their families, what we really need to be able to do is optimize treatment strategies, demonstrate improved outcomes, and advance these approaches beyond the individual physician level to really systems approaches to better identification of patients with FH and better treatment of the patients who get diagnosed. And in fact, this is where I think the field is right now, certainly where the foundation is focusing a lot of its effort. How can we do better in this real implementation aspect of the science? And so I'd like to kind of remind you that science and research can tell us what we can do. Guidelines tell us what we should do. Registries tell us what we're doing. But implementation science really tells us how to do it better. And we are making a major effort to try to use this nascent field of implementation science applied to FH to really better apply what we know and what we know works more systematically and more effectively to improve overall outcomes in patients with FH. Finally, in one slide, I just want to remind you of the amazing new therapeutic developments that have occurred in the FH and lipid disorder space. And in this slide, I've basically shown 4 different types of therapeutic approaches with approved medications and then other medications that are currently in development. So for example, on the left, small molecules. Of course, we have statins and ezetimibe. Thrilled to have a new addition to the armamentarium as a small molecule bempedoic acid. Lamidopide, a medication, as you know, that specifically is approved for homozygous FH targeting MTP. And then I'll just remind you that, in fact, there is a CTP inhibitor, obicetrapib, that is still in clinical development, very specifically geared toward LDL lowering. Now, of course, antibodies are another approach. We all know about the PCSK9 inhibitors. These are very effective medications. They're still underutilized, but very effective in reducing LDL and cardiovascular risk. There's an antibody called evinacumab that's in development targeting ANGPTL3. There's another antibody targeting ApoC3. So these are some approaches using antibodies. One of the really exciting areas of development has been nucleic acid therapies. And of course, mipomersen targeting ApoB was approved several years ago for the treatment of homozygous FH. Volanesorsen targeting ApoC3 is approved in Europe for familial chylomicronemia syndrome. And then there are several others in development. Inclisiran, which targets PCSK9, it's an siRNA. Buprenorphine, which targets ANGPTL3, an antisense oligonucleotide. And I'm sure many of you are aware of ApoA-LRX, the LPA antisense oligonucleotide that is in clinical development. And then finally, I'll just point out that really novel therapies like gene therapy and genome editing are definitely of great interest. We're actually running a gene therapy trial for homozygous familial hypercholesterolemia at Penn. And genome editing, of course, has great promise as a therapeutic approach for treatment of FH and other lipid and cardiovascular disorders. So lots of progress has been made in the translational therapeutic space. So we really have even greater ability to treat patients with FH once we identify them and realize that, in fact, they need more intensive therapy. So I'll come back to the barriers that I mentioned back in 2012, and then really come up to 2020 and point out that while there's still a lot of work to be done, many of these barriers have been addressed. So, for example, we now have this ICD-10 code, excitingly. The awareness of FH certainly has improved quite substantially in these 8 years. The genetic testing issue with this report is starting to really pick up, and in fact, a lot of lipidologists in particular are beginning to do genetic testing, or at least offer it to their patients with FH. The issue of a registry really has been met by this robust Cascade FH registry, and that continues to go on. And again, this concept that many patients, in fact, the vast majority of patients with FH have never been diagnosed, is really being addressed by this broad, ambitious national Find FH project to use machine learning to flag, identify, network, and deliver new patients with FH and really get them onto appropriate therapy. And then finally, some of the underutilization of existing therapies and the unmet LDL lowering needs that existed back in 2012, many of those have been met with new therapeutic approaches that have been approved since then, and with greater attention to trying to more effectively use the medicines that we have. So I'll end there, and I'd like to specifically acknowledge the FH Foundation, the amazing team that they have, led by Catherine Wildman, the CEO. I mentioned Kelly Myers, and there are several other individuals on this slide who are really critical components of the team. Mentioned the FH Foundation Board of Directors, but most importantly at the bottom, all the patients and the community of clinicians and practitioners who are interested in FH, who recognize this as an area where we know so much and we know what works, but we simply have to figure out how to do it better and how to do it at scale. And it simply couldn't be done without the participation of the clinicians and the patients in this journey. So with that, I'd like to end and thank you once again for your attention.
Thank you, Dr. Rader, for an outstanding overview of the disease and the way ahead in treatment of what once was an under-recognized disease, and now we have a lot of opportunities for these patients. So now we're going to move on to a three-way debate, but before that, I'd like to introduce myself. I'm Azim Mallah from Houston Methodist. I'm the director of cardiovascular PET, and I'll be moderating a three-way debate looking at risk stratification in patients with familial hypercholesterolemia. The first speaker in this three-way debate is Dr. Lawrence Sperling. He's the Katz Professor in Preventive Cardiology in Emory University in Atlanta, Georgia. He's the founder and director of Preventive Cardiology at Emory Clinic, and he's gonna talk about lipids and inflammations, lipid and inflammation biomarkers. They are alive and kicking for risk stratification in FH. Dr. Sperling?
It is a pleasure to be with all of you here virtually. I have no conflicts related to this presentation. In the short time I have with you, I will talk about cardiovascular risk stratification. First, a little bit related to lipids and how we think about this, touch upon inflammatory biomarkers, and then lastly, I'll provide you with some overview comments related to cardiovascular risk stratification. First, lipids, as it relates to risk stratification. So as we think of our ACC-AHA risk estimator, and we, for each of our patients, should be adding their demographics, including their total cholesterol and their HDL cholesterol, should we think beyond these standard measures as far as lipids? And this is a figure from an ACC Clinical Topics. And it points out that as we think about the concept of risk reduction and residual risk, should we be thinking about measuring beyond LDL cholesterol? We have metrics and measures like ApoB, particle number, non-HDL cholesterol, and what is the potential utility of this, and how does this affect direct, indirect costs, and potentially patient care? Really, the very best paper that I think we can utilize to help think through this is a paper from the UK Biobank published in Circulation last year. This paper looked at 347,000 individuals without known ASCVD. And what was demonstrated was that ApoB, LDL cholesterol, and non-HDL cholesterol highly correlated with an R value greater than 0.9. But after adjustment, there was similar association with cardiovascular event prediction using any of these measures with a hazard ratio between 1.20 and 1.23. Once total cholesterol and HDL in the model were added, there was no further improvement with the addition of ApoB or any other measure of LDL. And then importantly, in patients taking statins, the C statistic or C index was only modestly improved by the addition of non-HDL cholesterol or ApoB. We published this paper now some time ago in JACC. And in this paper, we raised the question of LDL versus non-HDL versus ApoB. And you can see here in our table, non-HDL related to performance, ease of use, and practical limitations appeared to be advantageous. In fact, we titled this paper, Non-HDL, Do the Math, because everything you need to know to calculate non-HDL you learned in first grade. The cost of non-HDL is $0 and 0 cents. And so we should think about non-HDL as a secondary measure when we assess risk, especially for those who are on treatment. There may be some potential value in certain populations for ApoB and particle number. But non-HDL should be something we should think about. And then lastly, this is a recent paper, first authored by one of our fellows at Emory, Anurag Mehta. And Lp(a) is a genetic risk, probably causative factor, but we'll call it a marker right now. And in this paper, looking at two cohorts, one from Eric, one from the Dallas Heart Study, lipoprotein(a) modestly increased hazard ratio in these populations, and as did family history. And then if you added these two together, and the family history was a premature CAD, there was an additive joint association. So we absolutely want to remember to ask a detailed family history of premature atherosclerosis. Now let's move on to inflammatory biomarkers. Atherosclerosis is most definitely an inflammatory disease state from its initiation to the progression to the acute events. We now have targeted therapies, interleukin antibodies based upon the CANTOS trial. There are exploration with TNF alpha blockers. And then recently at the ESC meeting, the LODOCO 2 study with the potential benefit of colchicine in those with stable ASCVD. There is a risk score related to the addition of family history and HSCRP, the Reynolds risk score. And if we dial back all the way to 1997, this is the U.S. Physicians' Health Study. CRP appears to be, again, a modest marker of increased risk with a relative risk of about 1.2 or so in a population. Very nonspecific marker of inflammation, however. Many factors can affect low levels of systemic inflammation, such as obesity, use of hormone therapy, smoking, even diets, and how we sometimes are inactive in our daily lives. Looking at the C statistic, this is from the MESA study. If we look at CRP compared to the Framingham risk score, The C statistic is only minimally improved by adding CRP. The single risk stratifier that appeared to do best in this study, and as we look at reclassification of risk, is cardiac CT calcium scoring in the appropriate individuals. We've published several papers related to biomarkers and cardiovascular risk assessment. These two reviews, the first was, should we measure C-reactive protein on Earth or just on Jupiter? And then we put together a composite of some of the novel biomarkers for cardiovascular risk assessment, such as CRP, fibrinogen, LPPLA2, proteomics, myeloperoxidase, etc., MMPs. And these appear to have a small benefit to the C statistic. Many of them may be markers of risk versus a causal factor as well. When we begin to identify those at high risk, and we hopefully focus on optimal lifestyle, behavioral, and medical therapies, we should think that there still is residual risk. And this is a really nice figure by Paul Ritker, saying there may be differential approaches if we have a residual cholesterol risk versus a residual inflammatory risk. And now some just overview comments about cardiovascular risk stratification. Our goal, of course, is to identify those who are at increased risk, like this kayaker here as the great white shark approaches, and we should identify those at increased risk in the general population, but also even those living with established atherosclerosis and cardiovascular disease. It boils down to this receiver operating curve and the C statistic. So this is the line of chance right here. We should look at this as the ACC-AHA risk estimator, or another risk score we use for a population. And the dotted yellow line might be something that improves upon this, upward and to the left. Well, as a companion to the 2018 cholesterol guidelines, we published this use of risk assessment tools to guide decision-making in the primary prevention of atherosclerotic cardiovascular disease. Donald Lloyd-Jones used this acronym at ACC 2019, just the initials of CPR. We want to do CPR with our patients so we don't have to do CPR on our patients. So calculate first, then personalize, and then potentially reclassify. This graphic here tells us in a 10-year ASCVD risk assessment, there are 4 buckets: your low risk, your borderline risk, your intermediate or high. You absolutely want to start and begin the thread of a clinician-patient risk discussion. If there is uncertainty, consider cardiac CT calcium scoring as you begin to embark upon the journey of cardiovascular prevention. For the first time, we use the term cardiovascular risk enhancing factors for this clinician-patient risk discussion and related to clinical decision-making, a family history of premature ASCVD, primary hypercholesterolemia, the presence of metabolic syndrome, CKD, chronic inflammatory disease states, evidence of pregnancy-related conditions, high-risk ethnicities, and then not to say that we should be measuring this in all of our patients, but if there is a measurement and an elevated CRP and Lp(a) and ApoB, this might sway us in terms of our clinical decision-making. This bell curve distribution is how we start thinking about population risk assessments, recognizing that we overestimate risk in some individuals, especially those at higher socio-demographic status. We may underestimate risk in those populations. Frequently women, those with inflammatory disease states, the younger individuals, and those with low SES. And the question is whether we should develop and utilize a polysocial risk score, which is used in some of the European risk estimators out there. So really, our social determinants of health are very important. And these social factors influence health and our risk in complex and interrelated ways, and may help better target interventions and resources effectively across populations. So how do we think about risk assessment beyond that 10-year absolute risk, or thinking about lifetime risk or a relative risk in individuals related to their peers? This is a great paper from Mark Lackey in Circulation 10 years ago now. Definitely want proof of concept, prospective validation. These measures or markers or ways of looking at bettering our risk assessment should have incremental value, clinical utility, but also be based upon really well done clinical outcomes data and be cost effective. So my take-home messages are for lipids and inflammatory biomarkers as they relate to cardiovascular risk stratification. We want to use appropriate lipid markers, and most of the time this is just using the traditional cholesterol panel, although selectively thinking about ApoB, particle number, definitely considering lipoprotein delay for the right individuals, those who have premature ASCVD, a strong family history, accelerated atherosclerosis. And I do think now that we're in the world of PCSK9 inhibitors, recognizing that the Friedewald equation leaves us short in terms of a true, accurate LDL. So there's the Martin-Hopkins equation or an NIH equation, which may help us there. Inflammatory biomarkers, we potentially may utilize these in residual risk. And now that we do have inflammatory direct targeted therapies, in whom would these be beneficial? But we definitely need validation, incremental value, and impact on outcomes and cost effectiveness. With that, I thank you and look forward to our upcoming discussion and debate. Thank you very much.
Thank you very much for a great talk on the role of lipids and inflammation and the residual risk. We're gonna move on now to the next talk, and this will be given by Dr. Christy Ballantyne, who is very well known to this audience. He's the chair of cardiology at Baylor College of Medicine and professor of medicine and vice chair of research. And he's going to talk about genetic markers of cardiovascular disease. The future is here. Christy?
Hi, I'm Christy Ballantyne. It's my pleasure to discuss with you genetic markers of CVD risk. The future is here now. These are my disclosures. So I'm focusing from the lipid aspect primarily. When do we do genetic testing? And it's usually when we have a striking clinical phenotype. So what are the possibilities? Very high LDL, mixed dyslipidemia, very high cholesterol and triglycerides, very high triglycerides, particularly the extreme elevations when you get chylomicronemia, very low levels of HDL, high LPA, and very low levels of LDL cholesterol or ApoB. There's been a very nice clinical summary in JCL that I would refer you to, which can guide you also in your practice. Now, we used to talk about the Fredrickson phenotypes, and the top two are the major indications for genetic testing. The first is extreme elevations. This would be of triglycerides. Usually they'll get a lab test saying that it looks milky, and that's chylomicronemia. It's a rare disorder when it's truly hereditary. It's autosomal recessive. Multiple genes can cause this. And the other one is when you have high levels of LDL cholesterol, and this is most commonly our concern is familial hypercholesterolemia. You've heard Dan Rader talk about how important this disorder is, so I will simply point out that it's more common than we used to think. As a reminder, this is around 1 in 250. I was taught when I was training it was 1 in 500. So it is more common, in particular, if you were to go into the cardiac cath lab or the CCU, and particularly for premature MI, then it's going to be even more common than that. So it's important to think about, and for multiple reasons, but one of them is that if you have a genetic disorder, you've had a high LDL for your entire life. And so your risk for heart disease is much higher than someone, for example, who may be 50 years old and has a similar level of LDL, but it has not been as high for their whole life. Now, it's not always the LDL receptor. There are other genes besides the LDL receptor. ApoB binds to LDL, and so mutations in ApoB, PCSK9 gain of function, and there's also a rare disorder, autosomal recessive hypercholesterolemia, and this is can look like homozygous FH if pediatric presentation with premature atherosclerosis and cardiovascular disease, but it's due to a different genetic defect. If you are seeing a lot of lipid patients, it is important to be familiar with some other rare disorders which might require different treatments. One is phytosterolemia. These are due to mutations in ABCG5G8, and you end up with high levels of plasma cytosterol and campesterol. So it can present like FH. There can be tuberous xanthomas, joint arthritis. In this case, the major therapy you need to have is ezetimibe to block absorption, this excessive absorption of cytosterol and campesterol. Lysosomal acid lipase deficiency can present with high LDL, also sometimes elevated triglycerides. And this is a disorder which also requires a specific treatment. It's infusions of cevolipase alpha. Cerebrotinous xanthomatosis is a rare disorder of bile acid metabolism. You can get, once again, xanthomas and premature heart disease. In this case, the treatment is chenodeoxycholic acid. And very low levels of LDL or ApoB are due to mutations in MTPP or ApoB. Autosomal recessive, in this case, a low-fat diet and high doses of fat-soluble vitamin are important. Rare disorders, but important that we don't miss them. So what are the benefits of genetic testing? Well, you can make a definitive diagnosis of FH at the molecular level. It gives you some prognostic information, as we said. These are high-risk people. They need intensive therapy. There is data to show that when you get a positive diagnosis, there's some improvement in terms of the initiation of therapy. People are more likely to treat, adherence to therapy, and they treat more aggressively. Also, earlier detection can be done. Particularly if you were to do population screening, which we'll talk about. You can do cascade screening, and that's a highly sensitive and specific way to identify other family members. And it can be also reassuring because you can exclude other family members who don't have the same hereditary disorder. What are the concerns? Well, we have the United States has the GINA, Genetic Information Non-Discrimination Act, prohibits discrimination by health insurance and employers based on genetic information. There's also some protection from the Americans with Disabilities Act and the Affordable Care Act. It is important. There are some gaps in protection remaining because life, disability, and long-term care insurance discrimination are not covered under current U.S. laws, and I hope that in the future they may be. It's important to be more aware of this because the fact is that genetic testing is vastly more available and the cost has gone down within the last 5 to 10 years. So it's really much improved. You can get a single gene, you can get panels of genes. Usually they're targeted towards familial hypercholesterolemia. Price is dropping, and now it can be less than 500, some are less than 100. Costs may not be covered by insurance, so this may be an important issue to discuss with your patient. So we're talking about screening for a monogenic disorder, and this is usually done by sequencing a specific gene. And that's important. For example, here's a study of premature myocardial infarction, and about 2% of the people, 1.7%, had a monogenic disorder. That would put them at a 3.8-fold increase in risk. However, it turns out that that's only going to get a minority of individuals. This was looking now, what if you took a different approach? And this was looking at exome sequencing, a whole genome sequencing, excuse me. And now what you can see is that if you do a polygenic risk score, in addition to the set of 2 people, which you would also get out of whole genome sequence, those 2 for FH, but you get another 17 who have a high polygenic risk score, and they also have a high risk for having an event. Well, it turns out, and you'll hear more about it in the next talk, but basically, particularly older individuals, if you get clinical factors, lipids, and a CAC score, you get a lot of information. It's not going to improve risk assessment. So why do we need to do this? So I would bring a couple things out. First of all, what's happening in the public? What are consumers doing? And in 2005 was the first DTC company. 2017, the FDA approved DTC genetic health risk tests. And look what has happened. There's an explosion. So whether physicians are involved or not, our patients are getting consumer DNA testing. This is going up at a fantastic rate. So we have a choice with new technologies, and we can either say we don't want it. Here's a cartoon about let's not get that wheel out of here. We don't need this. Or we can embrace them. And specifically, what is the major problem with prevention as we practice it right now? Our major problem is too little and too late. In cardiology, we tend to be more like the firemen, a little more effective than throwing this bucket. But firemen, you know, our advanced heart failure transplant, we go into these dramatic life-saving, and it's very important work as compared to, here's the impact. If you have smoke detectors in a well-designed building, that's going to actually save more lives than firemen rushing in when you have a catastrophic blaze. So how can we change this? Well, genetic testing from early in life, you know if someone has something. So if we're going to do universal screening for FH, why not also look at LPA variants? Polygenic risk scores for not just heart disease, but diabetes and obesity. We could begin lifestyle interventions in childhood, target the entire family, and start therapy earlier on with inexpensive statins and blood pressure medications, along with the lifestyle if it was not effective enough. So this could be a very major difference in terms of the way we do prevention. I'd like to talk about a project that we are finishing at Baylor as a pilot project where we're implementing in our cardiology practice a sequencing of 158 genes, polygenic risk score, variants in LPA, and in addition to this, some pharmacogenomics. So we looked at 158 genes dealing with arrhythmias, cardiomyopathies, orthopathies, dyslipidemias, other CV-related factors. We gave a report back on pathogenic variants, polygenic risk score, LPA variants, and pharmacogenomics. And this report went to the physician and also to the patient. We found that about 32% of the individuals tested out of 677 had something that might change their practice, either a pathogenic variant, about 8.5%, an LPA variant, 21%, high PRS in the top 5 percentile. We only reported that of 9.5%. The pharmacogenomic was probably the weakest part because this was relative to Coumadin and simvastatin, our two drugs we don't use much. There were a number of genes identified, and here this shows the list. In 58 patients, there were 19 different genes across a wide variety of disorders, a lot with lipids, but also cardiomyopathies, arrhythmias, vascular problems. All right, so in conclusion, where do we stand right now? Well, that was showing what we can do. I'm not saying that we should all be doing that, but we are able to right now look at, with much less expensive sequencing, we can screen for monogenic disorders, and these are primarily focused on severe high LDL, not severe, but FH, the rare FCS patients with extremely high triglycerides. Risk assessment with polygenic risk scores is still in evolution. We don't have any standardized ways for all ethnic groups. The LPA variant has some limitations. In Houston, we have a very diverse population, and it doesn't work as well in Hispanics in particular. What we were doing is that needs to be taken up to the next level. However, I would propose to you that we are on the verge of something really big. And so we're not, this isn't something that needs to be done routinely in everyone. However, I do think it's going to be the future. It's very bright, along with what we're currently doing with this other clinical phenotyping with blood tests and also calcium scoring. Thank you very much for your attention.
Thank you, Christy. That was awesome. And I think we have a great opportunity with all these genes that you have been discussing. I think Khurram is not completely convinced because he still insists to give his last talk on the conference. And he's going to defend probably stress echo in these patients, or sorry, calcium score. I forgot Khurram does calcium score, and he's going to defend CAC testing. Why do you need anything else? Khurram?
Thanks, Moaz. I think I have big shoes to fill and a hard job trying to convince you and everyone else that for risk stratification, if you have coronary artery calcium testing, why would you need anything else? First of all, my deepest gratitude to Christy and Larry for joining us today in this very engaging debate. I will start out with the case of a 45-year-old male, a good friend of mine, a physician scientist in translational science with a remote family history of heart disease, hypertension that's well controlled, and his 10-year risk is close to being considered high enough needing statin. He's really concerned about his lifelong risk. And before I suggest anything to him and say him, he says that I know that you are going to recommend coronary artery calcium testing and that you're going to point me out to the fact that it's established in the guidelines, and like many thought leaders like Roger Blumenthal thinks this is the best tiebreaker in a case like him. Ron Blankstein might feel that his risk will be half if he had a calcium score of 0. Scott Grundy thinks that without calcium testing, there is a 40% chance that you will be overtreated. Alan Cromwell thinks that this is a test that you may not need a statin. And if you ask Well Fuster, he'll be much more blunt and said, if you have a calcium score of 0, forget about statins. But he's also concerned that not everyone is buying into it. And my dear friend John Mandrolo from Medscape thinks that this is a blind spot. Professor Darrell Francis thinks that apart from diamonds, there is nothing such thing as forever. The power of 0 is a fallacy. Peter Libby and Steve Nissen think this is a Pandora box to avoid. And my dear friend Christy is still not buying into the power of 0 and doesn't think that that is enough. So after this, I truly had to calm him down. And I said, my friend, you've been spending too much time on Twitter. Now there is a lot of hype there and you need to focus and be pragmatic. I've given this CAC lecture many times before. Let's do it one more time. So let's focus. It's not that difficult to understand. Now, let me start all over again with the basics. What we have learned in med school and now in real life clinical practice is that why we care about risk factors like genetics and abnormal lipids as they flow through the funnel causing atherosclerosis, which is the main culprit for future cardiovascular disease. Now, the reason I focus on calcium, the reason why calcium is the best, the reason why it is different, that it is the actual disease that integrates not only what your current risk is, but what you might have been exposed to, and more importantly, accounting for not only your vulnerability, but your resilience, because not everyone is going to respond the same way to the same exposure. And if you're interested in knowing if you're at a higher risk, there is nothing that beats the presence and a higher burden of calcium score, because this is the only marker that discriminates. It's able to reclassify a significant proportion of population that may truly benefit from treatment. But the main important feature is the absence of atherosclerosis. And just because you have higher risk, such as inflammation, multiple risk factor, dyslipidemia, you have a family history of premature heart disease or aging, actually up to a half of these individuals will not have a calcium score of any calcium. Now, calcium testing also overcomes another fallacy that if you're at a high risk, that you need treatment. In fact, there's 1 in 2 chance that if you're a candidate for statin, that you'll have a calcium score of 0, your Vascular is much less than the threshold our guidelines suggest for statin. And based on your preferences as a shared decision making, you can have flexible goals. Now, furthermore, we have shown that absence of calcium has performed better than any other negative biomarker. It's cost effective. And for those harboring any fantasy of benefit with statin treatment, in case your calcium score is 0, we have seen that in a 12-year follow-up, there is no benefit unless you have a positive calcium test. So what about if you have an elevated lipoprotein A, the new kid on the block? And I've seen many of those and raised that question on Twitter before. And in March, we witnessed that even among those with elevated Lp(a), if you have a calcium score of 0, as you can see here, there is no increased risk. And Christie's own colleagues at Baylor had questioned that even with multiple risk enhancing factors, as you can see here, if you have a calcium score of 0, there is no additional value, leading many of us questioning why even bother. Now, also Dr. Sperling himself has shown that in the multi-ethnic study of atherosclerosis, even if you have severe LDL that is greater than 190, there is 1 in 3 chance that you will have a calcium score of 0. And behold, even in a 13-year follow-up, risk is way below the threshold that you should be considered for treatment. Clearly, the power of 0 has passed yet another test. Now, if you're one of those, even with the highest risk, that is with the genetically confirmed familial hypercholesterolemia, something that Dr. Rader just earlier talked about, even among this group, about 40% would have a calcium score of 0. And as you can see, in an intermediate term follow-up up to 5 years, there are no events. And this is the calcium presence and burden is the only predictor of risk, even in this very high risk group. Now, furthermore, if you think you are going to get seduced by the polygenic risk score and believe Dr. Topol that this will help you decide who needs and who doesn't need treatment, I ask you to look at the MESA data that clearly shows that up to half of these individuals with the low polygenic risk score have underlying atherosclerosis, and nearly half of them considered high risk don't have atherosclerosis. So I think so you rather listen to Dr. Greenland, who thinks that many people, researchers will continue to search null markers, they'll talk about biomarkers, genetics, but in the end, de-risking and convincing patients to take a drug, there is no better thing than a calcium score. So finally, after giving this advice to my friend and this information, I asked him finally, how would you decide? Would you be reassured if you had a calcium score of 0 or normal biomarkers versus normal genetic risk score? Or you're going to be more concerned if you have a higher atherosclerotic burden, you had elevated LDL and LP or a high polygenic risk score. His decision was very clear. With calcium testing, why do I or any of you need anything? And my response to him was cheers to him and everyone else. And thank you so much for joining us today. Appreciate it.
Thanks, Khurram. And so let's continue the debate live right now with all the speakers. And while Khurram and Christy unmute their phone and microphone, maybe I'll start with the first question to Christy. Maybe it will give you a sense you didn't have a chance to see Khurram's slides. Maybe you can say a few words, Christy and Larry, about Dr. Sperling, about the role of calcium score. What do you think? Where does it fit in your practice?
I think it's a great test, but you have to remember 2 factors is, like any test, when is it used appropriately? And age and gender are 2 important issues. So if you do if Khurram says, well, if it's a 0, you don't have to use a statin. If I do a 15-year-old woman who's got FH with an LDL of 300 and she's 0, and I say I don't have to do a statin, he says, well, you won't have an event in 5 years. Well, I already knew that. In that case, it's a useless test for that. So like any test, you have to use the right. But if you look in older individuals, it's a fantastic test. And it's exactly right. I can't tell you how many women I've seen who had statin intolerance and everything else, but they end up having a high cholesterol and they have a 0 calcium score, and we congratulate them and work on their blood pressure and exercise and diet, but say, keep doing what you're doing with it.
Excellent. Dr. Sperling?
Yeah, thank you very much. Well, first of all, really wonderful that we will have a civilized debate here in the U.S. Khurram and Christy, we will follow the rules, and thank you for not interrupting.
I can mute the microphone, so.
Please do. Really, really great presentations, really elucidating many important points. I'm going to agree in many ways with Christy here. I've been in the space of cardiac CT calcium scoring for 25 years, and so I fully appreciate your presentation, Khurram. But why should we wait to risk stratify and utilize the power of 0, waiting for atherosclerotic calcification of vessels? Shouldn't we be risk stratifying at a younger age?
True.
Because there was a wonderful editorial in JACC just a week ago or a week and a half ago. Mike Shapiro wrote this great paper about a concept all of us have been talking about for many years, because risk factors exert risk over time. It's an integral, like in calculus, so cholesterol years. And so we actually understand risk in 8-year-old children today. Not to say we should be starting statins in all of them, or metformin or an SGLT2 inhibitor. But why should we wait for the population risk to get to the differentiator of yay or nay coronary artery calcification? Now, for an individual, and so age matters. Gender matters, age matters, ethnicity matters, and where we live matters as well. Because I mentioned social determinants of health. We don't put that into the equation. It's a really important determinant that we underappreciate. So I'll leave it at that. Thank you for not interrupting, by the way. That's great.
Maybe I'll ask Khurram about the calcium score. We know from MESA data and others, the rate of conversion is about 10 to 15% over 5 years. I think to withhold statins, and at least in the FH group, we probably should know the conversion rate of those who are zero in the FH community, at least. Don't you agree, before rushing into stopping statins in these patients?
So absolutely, I think so. Christy and first Larry, I totally agree with both of you. So the first clarification for calcium zero, and especially the power of zero, and if you ask Mike Blaha that calcium score of zero, and we have been advocating that it does not equate zero risk, and that's very clear, and especially in these uncertain cases. So I hope by next week you will see a piece of my mind in circulation that we'll be clarifying this issue, especially and saying in FH patients, and of course I'll love to hear Dr. Rader's view, is that the power of zero is truly not for statin decisions. So that's kind of, we have already clarified. I think so it's well established. If you have FH, statins are cheap, effective, everybody should be on it. What we are very intrigued, and of course Dr. Rader would love to get his comments, is that, and it's not an uncommon phenomena, we're seeing a lot of mid-40s, early 50s, and even up to 60-year-old individuals with severely elevated LDL, LDLs in 200s and 300s, unable to tolerate statin, and for some reason, for some unknown great reason, they are resilient to development of atherosclerosis. The question is, can we use some of those to identify those who may be candidates for more advanced and expensive therapy in FH? And as Dr. Sperling pointed out, I totally agree. For risk factors, you have to start early. But at the same time, we need to be cognizant of the fact that when we talk about risk, we are talking about average risks. And the trajectories, the long-term trajectories, all depend where you start from. And at the start, in our view, in the mid-40s at least, there are going to be 3 or 4 trajectories based on your calcium score, as you rightly showed in the MESA study, that even with severely elevated LDLs of greater than 190, if you follow these individuals for 13 years, their 10-year risk is 3.5. So not everyone with severe LDL, elevated LDL, is at high risk. I truly believe that we have tremendous amount of opportunity learning about vulnerability and resilience with these discussions, and truly the focus needs to move now towards the younger individuals, less than 40, in the FH population, using some of the CTA groups, and love to hear what Dr. Rader has to think about this heterogeneity in this pretty homogeneously elevated risk group.
Yeah, thank you. Thank you very much. I think that obviously there's heterogeneity in LDL levels among people with FH, but I think your point is heterogeneity in the actual development of atherosclerotic disease, even for a given level of LDL. There's no question that heterogeneity exists. Part of that, of course, is other genetic factors that impact with LDL to contribute toward increased risk. But specifically the point you made, the individuals who we all see who have quite high LDL levels in an FH range, and yet have been free of cardiovascular disease into an age when we would normally expect they should have had a problem. What's going on there? And are there people who are naturally resistant to the effects of a particularly elevated LDL? I will grant that that's possible, that there may be certain people who have protective vascular wall genetics that protect them against the impact of an elevated LDL. But my own personal belief is that mostly they've been lucky. Mostly they're individuals who, for whatever reason, haven't developed all that much disease, or they have disease, but they haven't yet developed symptomatic disease. And so I am very reluctant to say someone who has an LDL in an FH range to ever make the conclusion that they're not susceptible to the effects of that LDL and therefore don't need treatment. Now, I grant you, a 70-year-old who has an LDL of 220, who's had that LDL all his life and for whatever reason hasn't been treated, and you do a calcium score and it's 0, I might be willing to tell that guy, you know what, you're doing okay. But I think the vast majority of individuals in that range, I would try to at least convince them to go on treatment. And I probably wouldn't even try that hard to get a calcium score. I would mostly say, listen, you're in a range that you need treatment. But this is definitely a topic for debate, and we could, I'm sure that there may be others on this panel who don't necessarily agree with that point of view.
So maybe a question to Christy. I mean, nice study and that you showed that you guys have done on 600 or so patients from Baylor and identifying all these genetic susceptibility to disease. How did that impact the resource utilization in these patients? I mean, somebody who has got an cardiomyopathy kind of gene tested positive, or even if they don't have the phenotype, did that result in increased resource utilization, anxiety, did medication?
So we're looking at these things now, but basically there were some more imaging tests done, obviously, in terms of this. There was also a concern in terms of some of them needing a genetics consultation for other family members. Lowest DC is one, which is a different prognosis with it. And there was also, so this is something else. So measuring an LPA level, if it's a good lab, you get all the information. You don't need the genetics, but it turns out that most of our cardiologists, I'm embarrassed to say, don't measure LPA levels. So when you get a genetic variant, it triggered a number of people to measure LPA. It is a problem right now, as I said, is that we were using some data, and those from European ancestry. They don't work in Hispanics, and so since Houston's a very diverse, we had a lot of false values. I mean, they were kind of false negatives. It doesn't work in Hispanic populations.
Okay.
And we also were trying to figure out what did the patient think about it, and what did the physicians think about it? So we're doing some work with our an outcomes group, trying to get a better idea of this. It was a challenge getting this into the EMR, and then also getting it to the patients. And we kind of limited some, like only give the top 5% of PRS because we think it's too much data, giving all the rest of it. Our cardiologists are busy.
Okay.
So I have a question for both Larry, Christy, and Dr. Rader, and Dan here too. So, most of our risk assessments, apart from maybe for looking for if you have a strong family history of premature heart disease for FH, is mostly limited to age 40 and above. If you look at the guidelines, that's kind of where it is. But very rightly so, I think so. We are moving into that sweet spot where we have the capacity. I think so. We have the tools, and now we can properly manage moving that whole paradigm to a younger population. Now, 3 challenges that I see, and I loved Larry to give his thought first, is what tools should we be using to really assess risk in the young, number one. And with Christy, if we are looking for improvement in outcomes, would there ever be a clinical trial to suggest there is an improvement, which is almost going to be, I don't think so that's going to happen. So, and then Dan, do you think that CTA or incidence of plaque and plaque progression could actually become an outcome in this age 30 to 40? So starting from Larry, how would you assess risk? What should we be doing if we find risk? And then should we be using incident plaque formation or progression of plaque formation as an outcome? So wide open questions for all three of you.
First, to address the question of risk or risk in the young, and it'll come back to our debate here. If we're debating about what is the best single way to risk stratify those in terms of FH, if that is the question of the debate, that's clear. In terms of cost benefit, and risk benefit, it would just be get an LDL and ask a family history, which there's no cost, there's no radiation, and there's no complexity of talking about the genetics. And we know that F plus H equals FH. Now, in terms of screening the young, in the UK, there was a publication, I believe in the New England Journal of Medicine by Law. It was either Wald or Law, it was the younger one, screening at birth. And so really that, if we're really looking at a risk over a lifetime, you could make a case, and the argument against it is cost effectiveness, and that you wouldn't necessarily treat at birth or right thereafter. But really, you can incorporate an LDL cholesterol as part of the newborn screening if you really want to impact a disease across one's life. And then by finding those newborns, you'd reverse cascade screen. You'd be finding, the families of these children. Now, we can screen children for obesity, which is going to be a marker of, metabolic risk for diabetes. So many things we can do at a younger age. And I do believe we should dial back our risk assessment in terms of a lifetime strategy for cardiovascular disease prevention.
So just to clarify, if this was a non-FH patients, which was mostly the idea, with FH, we know we have to screen, we have to treat, we find people, you identify them as young as possible, you start treatment as young as possible, but taking the lessons learned for non-FH patients, how would you advocate the risk assessment, what treatment should we happen, and what type of outcomes that we should be looking for?
Oh, you could connect cardiac risk assessment to school-age children, which has been done in the country of Slovenia. And by the way, Slovenia has invested 2 decades. They have a population of 2 million, but over 2 decades, Slovenia is one of the few countries in the world where cardiovascular deaths are number 2. So absolutely can do that.
Throw an idea out for Dan, but we already do. For example, that people at birth, everyone gets screened in the state of Texas for congenital hypothyroidism. Now that's a pretty rare disorder, but it's very treatable. I happen to have a nephew who had that, so I was glad they got screened with it. And they're screening for genetic disorders, but I don't know why it would be that with the technology that's going to be available, it's already there, but in terms of at birth, you could screen for important monogenic disorders. And I think the polygenic for obesity, diabetes, cardiovascular disease would have a family approach. The whole family works on lifestyle. And I think family approaches would make sense. It doesn't mean you use drugs, but you could do some education of these things. I don't think it's that wild of an idea. Now, I would love to test it. It'd be a big study, but we've got all of us. Dan, maybe you can organize that, and we'll be a site. We'll be happy to work with you for it. But I think it could be the future. That's just a thought.
Dan, your thoughts?
Well, I'm all for trying to identify risk early before disease presents. I think the earlier we can push it, the better. I think that study by Wald et al. In New England Journal was a very nice study. They screened at age 2 and took advantage of immunizations occurring in the UK at age 2 and did basically a finger stick for cholesterol. They picked up, not a whole lot, but they picked up definite new FH patients. They cascaded upward to their parents. It was a very nice study, and we've had a lot of discussion about could that be implemented in the US. I think Christy touches on a related point, which is we're certainly entering an era of genomic medicine, where the sequencing is so cheap, will be so cheap, that applying sequencing, even whole exome sequencing, at an early stage is something that will allow us to pick up all sorts of predispositions genetically to important diseases like FH and others, and allow us to intervene. And therefore, I think that's the way we're going, and I'd like to see things move in that direction even more actively over the next decade, and I predict that they will. I think that's the way we're ultimately going to identify a lot of these patients at an early stage where we can intervene and really make a difference, as Larry says, before they ever present with any kind of clinical manifestation of disease.
So one last question that's came up from the public, as everybody realizes, and I'm a firm believer, genetics is the first risk factor, as my dear friend Pradeep Natarajan says. This is really what it is. So when do you assume that the polygenic risk score will become prime time and available? Are there available resources? Do you know of any labs that we send right now? If not, when should we expect them to be in the market?
I think the problem is that there are already some in the market, but that there's not a consensus, and different ethnic groups and how well they work. And I guess Dan, you're probably involved with this some, but it's a bit of a mess right now in terms of, I think it's like when you do a lab result. It was like LPA was 20 years ago. You had all these different ways of measuring LPA, and some of them were no good, some of them were good. So there needs to be a lot of work done. Dan, are you involved with any attempts to formalize this?
Yeah, I mean, we're working on standardizing and setting up a polygenic risk score for coronary disease for use in our preventive cardiology clinic, really geared toward the same types of patients you might use coronary calcium scanning, or maybe even more so the younger people who coronary calcium scanning is not useful. You're on the fence. Do they have, they have an LDL that you might treat, but not necessarily a high polygenic risk score for coronary disease, in my opinion, in that type of patient might tip you more toward considering statin therapy. I think that's the patient population that this might be useful. But there are, as Christy says, a lot of issues around standardization of these scores. There are huge issues around the impact of ethnicity on these scores and how they perform. And we're trying to work through that. I'll just say that there's this big NHGRI eMERGE consortium, and the next version of eMERGE is focused on standardization and clinical application of polygenic risk scores for 15 different traits. And so that's something that I think they really want to focus on over the next few years, and then ultimately disseminate that.
Well,
I think it's already, I'll leave it to you, Khurram.
Well, I just want, this discussion can go on forever, and I'm very excited about the new developments, and I hope that next year we'll hear more. I think so this is really the future, if we can truly take this information of genetics and biomarkers and identify those at a very early stage. Now, the question for all of us would be, how do we treat them aggressively, and what pathways, of course, lifestyles for everyone, who would be the most appropriate candidates to benefit. But again, thank you so much, everyone, all the participants joining us for our first annual Cardiovascular Disease Prevention Symposium. And by the way, in the spirit of prevention and in the current challenges that we are facing, it's not only about prevention of heart disease, I think so prevention of everything else we do. Eat well, eat your carrots, move around, lose some weight. At the same time, wear a mask, have social distancing, and wash your hands as much as possible. And everyone be safe, and thank you so much. Hopefully in the next 12 months, when we have our next symposium, we'll be able to meet each other in person. Till then, be safe. Thank you so much.
Thank you.
Thank you.
Thank you.
Great meeting.